Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
In the comprehensive realm of toxicology, understanding the diverse profiles of heavy metal poisoning is paramount. This content delves into the intricate aspects of several key elements: antimony, arsenic, cobalt, mercury, thallium, and zinc, along with a crucial distinction for elemental phosphorus, which, while highly toxic, is fundamentally a non-metal. This module will explore the varied forms, how they are absorbed, distributed, metabolized, and excreted by the body, and the ways in which these substances cause disease at the cellular and organ level, leading to systemic effects. Clinical presentations, which are often multi-systemic and dose-dependent, will be thoroughly reviewed alongside life-threatening complications. Crucially, diagnostic approaches, including specific laboratory testing and imaging, will be discussed. Finally, this module will highlight the cornerstones of management, including supportive care, decontamination strategies, and the nuanced application of chelation therapy. It is important to recognize that elemental phosphorus necessitates a distinct approach from classic heavy metals due to its nonmetallic nature and different toxicological mechanisms. This comprehensive overview aims to equip healthcare professionals with the essential knowledge for prompt recognition and effective intervention in cases of elemental and heavy metal toxicity. A comprehensive understanding of the diverse landscape of elemental and heavy metal toxicology is critical for effective patient management. Upon reviewing this content, you should be able to distinguish between the various forms of antimony, arsenic, cobalt, mercury, thallium, and zinc. You should also correlate their chemical properties with their respective toxicokinetics and predominant routes of exposure. Furthermore, you should be able to describe the key pathophysiological mechanisms by which antimony, arsenic, cobalt, mercury, thallium, and zinc exert their toxic effects at a cellular and systemic level, including their interactions with enzymes and essential ions. You should also be able to recognize the distinct clinical presentations and multisystemic manifestations characteristic of acute and chronic poisoning by each element, including life-threatening complications. You should be able to identify the specific diagnostic modalities, including appropriate laboratory tests, for example, blood, urine speciation analysis, and imaging utilized to confirm the diagnosis of poisoning by each element. You should also be able to formulate an initial management plan for acute ingestions of these elements, emphasizing the principles of supportive care and appropriate gastrointestinal decontamination strategies. It is important to apply the principles of chelation therapy where indicated for trivalent antimony, arsenic, cobalt, and elemental or inorganic mercury poisoning. This includes differentiating between appropriate chelating agents, for example, dimercaptosuccinic acid, dimercaptopropane sulfonate, British anti-leucite, calcium disodium edetate, and acetylcysteine, based on the specific element and its toxic form. You should also critically evaluate contraindications and limitations of certain therapeutic interventions, such as the use of dimercaprol in organic mercury poisoning or potassium supplementation in thallium poisoning. Additionally, you should be able to differentiate the toxicological profile and management approach for elemental phosphorus from that of classic heavy metals, recognizing its classification as a non-metal and the absence of a specific antidote or chelating agent. You should also be able to explain the specific treatment strategies for thallium poisoning, focusing on enhanced elimination with Prussian blue and understanding its mechanism of action and side effects. Finally, you should describe the unique management strategy for chronic zinc toxicity, specifically addressing the resultant copper deficiency through targeted supplementation. Antimony is a metalloid that is naturally found in the Earth's crust. It plays an important role in the field of heavy metal toxicology, often showing similarities to arsenic. Throughout history, antimony has been used both in therapeutic applications and industrial processes, which has led to both beneficial uses and toxic exposures. This element is located in group 15 of the periodic table, with an atomic number of 51 and an atomic weight of 121.76. It sits below arsenic and above bismuth. Historically, antimony has been considered less toxic than arsenic, but more toxic than bismuth. It exists in 4 oxidation states: 0, +3, +5, and -3. The most common oxidation state is +3. In aerobic environments, antimony tends to be in the pentavalent state, while in anaerobic conditions or during human activities, it is often found in the trivalent state. In the medical field, pentavalent antimony compounds such as sodium stibogluconate and meglymine antimoniate have been essential in treating leishmaniasis, a disease affecting various parts of the body, including visceral, mucosal, and cutaneous areas. Industrially, elemental antimony is used in semiconductor devices, infrared detectors, and diodes. It is also commonly alloyed with metals like lead, copper, and silver to enhance their hardness, mechanical strength, and resistance to corrosion. Antimony trioxide is widely applied as a fire retardant, and antimony trisulfide is used in lead batteries, paints, ceramics, and glass. Occupational exposure to antimony primarily occurs through inhaling dust or fumes generated during processing or recycling activities. Such environments often contain other toxic metals, including arsenic and lead, which can compound the health risks associated with antimony exposure. The absorption of antimony varies significantly depending on the route of exposure and its chemical form. When ingested orally, antimony compounds are generally poorly absorbed through the gastrointestinal tract, with about 15% absorption for all forms and less than 10% for antimony tartrate. This process is thought to be saturable. In cases of acute ingestion of lethal doses of antimony tartrate, total absorption may occur within 2 hours. When inhaled, the absorption of antimony depends on particle size and water solubility. Aerosols containing small, low water-soluble particles, such as antimony oxides, tend to be retained longer in the lungs than larger, more water-soluble particles like antimony tartrate. Inhaled antimony can remain in the lungs for extended periods without significant systemic absorption and distribution. Transdermal absorption, or absorption through the skin, also occurs, although details are less clear. Once inside the body, the distribution of antimony is influenced by its valent state. After inhalation, both the trivalent and pentavalent forms tend to concentrate in red blood cells and plasma. The trivalent form is reported to accumulate in the liver, whereas the pentavalent form tends to accumulate in the skeleton. Some other distribution patterns have also been observed. When administered either intravenously or orally, antimony primarily distributes to highly vascular organs such as the liver, kidneys, thyroid gland, and adrenal glands. The liver and spleen predominantly accumulate the pentavalent form, while the thyroid gland accumulates the trivalent form. A pharmacokinetic model describing the movement of pentavalent antimony after intramuscular administration proposes 2 phases. The first, a fast phase, has an average half-life of approximately 2 hours, while the second, a slow phase, has an average half-life of about 76 hours. The prolonged elimination phase is believed to result from the conversion of pentavalent antimony to the trivalent form. Regarding metabolism, antimony's methylation process is limited compared to arsenic, indicating that trivalent antimony is less effectively detoxified. Trivalent antimony can bind to glutathione and be excreted in bile, but this bond is unstable. As a result, Enterohepatic reabsorption, or reentry into the bloodstream from the bile, can occur. In terms of excretion, pentavalent antimony is mainly eliminated through urine, whereas trivalent forms are primarily excreted in feces. More than 80% of intravenously administered antimony compounds are excreted in urine within 6 to 8 hours. The half-life of antimony in urine is approximately 95 hours. When inhaled as stibine, the renal elimination half-life is about 4 days. Antimony toxicity closely resembles arsenic toxicity due to their chemical, physical, and physiological similarities. Antimony interacts with sulfhydryl groups of enzymes and proteins. In vitro studies suggest that it inhibits enzymes such as succinic oxidase, pyruvate oxidase, and phosphofructokinase, thereby interfering with cellular respiration. Compounds of trivalent antimony are generally more toxic than those of pentavalent antimony because they have a higher affinity for erythrocytes and sulfhydryl groups. Regarding cardiac effects, trivalent antimony can prolong the action potential of ventricular myocytes by increasing calcium currents, a mechanism similar to that observed with arsenic trioxide. On a cellular level, the anti-leishmanial effects of antimony are attributed to the depletion of adenosine triphosphate due to interference with glycolysis and the beta-oxidation of fatty acids in the leishmaniasis-causing organisms. Additionally, the generation of reactive oxygen species and the subsequent depletion of glutathione contribute to apoptosis, which is associated with antimony toxicity. In terms of gastrointestinal effects, antimony salts are irritants to the gastrointestinal tract. Their mechanism of action involves the activation of enterochromaffin cells, leading to the release of serotonin and stimulation of the vomiting center in the brain. At higher doses, antimony can also exert a direct central action on the medulla, further contributing to vomiting. Antimony poisoning can impact multiple organ systems, with symptoms varying depending on the route of exposure. When ingested acutely, antimony primarily affects the gastrointestinal tract, leading to nausea, vomiting, watery diarrhea, abdominal pain, black tarry stools, and vomiting blood. These symptoms can result in significant fluid loss and potentially cause hypovolemic shock. A metallic taste and a garlic smell on the breath may also be observed, although the latter can sometimes be mistaken for arsenic exposure. Chronic exposure to antimony dust in occupational settings has been linked to an increased incidence of gastrointestinal ulcers. Additionally, pancreatitis may develop following treatment with antimonal compounds. In terms of cardiovascular effects, toxicity to the heart is the most concerning adverse effect of pentavalent antimonal therapy, even when used at recommended doses. This toxicity can manifest as elevated blood pressure, changes in the T wave seen on electrocardiograms, prominent U waves, and prolongation of the QT interval. Severe cardiac events include premature ventricular contractions, first-degree atrioventricular block, ventricular tachycardia, torsade de pointes, and sudden cardiac death. Fortunately, these changes are often reversible upon stopping treatment. Notably, chronic exposure to antimony alone does not seem to increase the risk of ischemic heart disease. Pulmonary effects involve irritation of the mucous membranes following inhalational exposure, resulting in sore throat, conjunctivitis, nasal inflammation, and nosebleeds. Long-term occupational exposure to airborne antimony compounds is associated with pneumoconiosis, which can present as a cough, wheezing, difficulty breathing during exertion, and in some cases, obstructive lung disease. Acute inhalation of antimony pentachloride has been reported to cause respiratory distress syndrome, a severe lung condition. Less commonly, antimony oxides can cause metal fume fever, with symptoms similar to those caused by zinc oxide fumes. Hematologic effects include the frequent occurrence of leukopenia or a reduction in white blood cell count in patients treated with antimonal medications. Exposure to stibine, a highly toxic form of antimony, has been associated with acute lung injury and hemolysis. Stibine can cause intravascular hemolysis by binding to oxidized hemoglobin, an effect similar to that seen with arsenic gas. Antimony exposure can also impact the kidneys and liver, potentially leading to acute kidney injury and hepatic injury. Renal tubular acidosis has been reported as a side effect of treatment with pentavalent antimony compounds. In the skin, dermatitis and characteristic antimony spots have been observed in workers exposed to antimony. Skin hypersensitivity reactions may also occur during antimonial therapy. Musculoskeletal pain is a common adverse effect, sometimes severe enough to require stopping treatment. Regarding metabolism, antimony is recognized as a metalloestrogen, and prolonged exposure may increase the risk of developing diabetes. In terms of reproductive health, animal studies suggest that antimony can cause ovarian atrophy, changes in the uterus, and impaired conception. There have also been reports of spontaneous abortion and premature births in women occupationally exposed to antimony. Regarding carcinogenicity, female rats exposed to antimony trioxide and trisulfide developed lung tumors. The International Agency for Research on Cancer has classified antimony trioxide as possibly carcinogenic to humans. However, establishing a definitive cause and effect relationship in humans is complicated by factors such as concurrent arsenic exposure and smoking habits. Antimony toxicity should be considered in patients who present with gastrointestinal or pulmonary symptoms or electrocardiogram changes. This is especially important for individuals treated for leishmaniasis or those working with antimony compounds. Diagnosis is confirmed by measuring antimony concentrations in blood, urine, or both, typically using atomic absorption spectroscopy. The normal serum antimony concentration is approximately 3 micrograms per liter, while the normal 24-hour urine collection shows a concentration of about 0.8 micrograms per liter. Other sources report that unexposed patients usually have a urinary antimony concentration of less than 6.2 micrograms per liter. It is important to note that a serum antimony concentration cannot be determined in a timely manner. An abdominal radiograph may be useful in cases of ingestion, as it can help assess the gastrointestinal load of antimony and guide decontamination efforts. The use of non-validated methods such as hair sample analysis to determine antimony toxicity is strongly cautioned against by the Centers for Disease Control and Prevention. The treatment of antimony poisoning involves supportive care, decontamination, and chelation therapy. For acute ingestion, aggressive intravenous administration of crystalloids with appropriate cardiovascular monitoring is essential to replace fluid loss and manage hypovolemic shock. In cases where shock is unresponsive to fluids, the use of vasopressors or inotropes may be necessary. Continuous cardiac monitoring should be implemented if electrocardiogram changes, such as prolongation of the QT interval or other significant manifestations of poisoning, are observed due to the increased risk of torsade de pointes. To improve patient comfort and facilitate administration of activated charcoal, antiemetics are recommended. Following exposure to antimony compounds, it is important to closely monitor hemoglobin concentration, and blood transfusions should be administered as needed. Early exchange transfusion may be considered in cases of acute exposure to antimony compounds. In terms of gastrointestinal decontamination, most patients who ingest antimony will experience vomiting. Activated charcoal might theoretically be effective in reducing absorption if administered within the first 1 to 2 hours after ingestion. However, its ability to decrease absorption in cases of acute poisoning has not been directly studied in humans, and there is no data indicating that it improves patient outcomes. Whole bowel irrigation may also have a role in treatment, similar to its use in arsenic poisoning. Chelation therapy for antimony poisoning has limited human data, with most information derived from animal studies. Dimercaprol, also known as British antiluicite, has been reported to reduce the toxicity of antimony potassium tartrate in rabbits and to lessen toxicity during treatment with other trivalent antimonal drugs. It is administered via intramuscular injection. However, dimercaprol can redistribute mercury and arsenic to the brain, and its effect on antimony redistribution is not clearly defined in all situations. Derivatives of dimercaprol, such as 2,3-dimercaptosuccinic acid, commonly known as succimer, and 2,3-dimercaptopropane, 1 sulfonate have demonstrated efficacy in animal models by decreasing mortality in mice given antimony tartrate. Among these, succimer is considered the most effective chelating agent studied in animals. Dipenicillamine has been found to be less effective than the other agents in animal models. Current recommendations for treating poisoning from trivalent antimony are based on limited evidence. Oral administration of succimer at a dose of 10 milligrams per kilogram every 8 hours for 5 days, followed by the same dose every 12 hours for 14 days, may be considered ideally initiated as early as possible. If the patient experiences intractable vomiting preventing oral intake, dimercaprol may be used as an alternative. Chelating agents should be administered at doses proven safe and effective for other metals such as arsenic, considering their similarities. Additionally, N-acetylcysteine has been used in at least one case report as a glutathione precursor to facilitate conjugation with antimony and promote its excretion through enterohepatic pathways. For toxicity related to pentavalent antimony, current data do not support the use of chelation therapy. The duration of chelation treatment should be guided by the clinical response of the patient. It is important to maintain a high index of suspicion for antimony poisoning, whether due to occupational exposure or therapeutic use, because its clinical manifestations are diverse and often mimic arsenic toxicity. While supportive care remains the mainstay of treatment, chelating agents like succimer and dimercaptopropane sulfonate may be considered for trivalent antimony poisoning, though their effectiveness in humans needs further robust investigation. In the comprehensive field of medical toxicology, arsenic poisoning is a significant concern due to its various forms, widespread presence in the environment, and extensive effects on multiple organ systems. Historically, arsenic has gained notoriety as a substance used for homicide, but it has also reemerged in recent times as a medicinal agent for treating conditions such as acute promyelocytic leukemia, highlighting its complex relationship with human health. Understanding arsenic involves examining its different forms and the epidemiology of exposure. Arsenic is a silver-gray metalloid that rarely exists in its elemental form in nature because it has low solubility, which generally prevents human toxicity. Instead, human exposure mostly involves inorganic arsenic salts and natural or synthetic organic arsenic compounds. The toxicity of these compounds varies widely depending on their molecular structure, valence state, solubility, and circumstances of exposure. Inorganic arsenic primarily occurs as soluble crystalline solids and salts of trivalent arsenic known as arsenite and pentavalent arsenic called arsenate. Compounds of trivalent arsenic tend to be more acutely toxic than those of pentavalent arsenic, although in vivo interconversion between these forms can occur. Both types can produce similar patterns of intoxication, whether acute or chronic. Notable examples include arsenic trioxide, a crystalline solid used commercially, and arsenic pentoxide. In many countries, contaminated groundwater is the main source of large-scale chronic arsenic toxicity outbreaks, with notable incidences in Bangladesh, Chile, Taiwan, India, Mexico, and Argentina. Regulatory agencies, such as the United States Environmental Protection Agency and the World Health Organization, recommend that arsenic levels in drinking water not exceed 10 micrograms per liter or 10 parts per billion. Organic arsenic compounds, like arsenobutane and arsenosagars found naturally in fish and shellfish, generally have very low toxicity. However, certain organoarsenic medications, such as melarsoprol used to treat African trypanosomiasis, are highly toxic and pose significant health risks. Arsine is an extremely toxic, colorless gaseous form of arsenic. It is released when inorganic arsenic-containing materials come into contact with nascent hydrogen. Industrial accidents have resulted in severe poisonings, particularly when metal ores or alloys that contain arsenic, like aluminum or zinc, interact with acidic or sometimes alkaline solutions. Poisoning by arsine is distinctive in that it causes intravascular hemolysis, which is the destruction of red blood cells within blood vessels. Arsenic's acute and chronic non-cancer toxic effects stem from its extensive interactions with cellular proteins, cofactors, and nucleic acids. When arsenic is in its trivalent form, known as arsenic 3 or arsenic in the trivalent state, its primary biochemical effect is to inhibit the pyruvate dehydrogenase complex, which is essential for the tricarboxylic acid cycle. Additionally, arsenic in this state, along with monomethyl arsenous acid, is a potent inhibitor of enzymes crucial for protecting cells against oxidative stress, such as glutathione reductase and thioredoxin reductase. Exposure to arsenic in this form is associated with the production of reactive oxygen radicals, which can lead to mutagenesis and cell death. In its pentavalent form, arsenic, also known as arsenic 5, includes arsenate and methyl arsenicals. These compounds are often reduced within the body to trivalent species, which then bind to proteins, interfere with enzymatic functions, or increase oxidative stress. Arsenate can also disrupt cellular energy production by substituting for phosphate during phosphorylation reactions, resulting in depletion of adenosine triphosphate, the cell's energy currency. Inorganic arsenic undergoes biomethylation primarily in the liver, converting it into more water-soluble monomethylated and dimethylated metabolites. While these metabolites are generally less acutely toxic, small quantities of methylated species in the trivalent state are produced, which are more toxic than the inorganic form of arsenic. Therefore, methylation should not be considered solely a detoxification process. Genetic differences affecting the efficiency of methylation are linked to a heightened risk of chronic health impacts related to arsenic exposure. The widespread presence of arsenic's biochemical targets across various cell types throughout the body explains its tendency to cause effects in multiple organ systems. This multisystemic clinical presentation is characteristic of arsenic toxicity. The manifestations of arsenic toxicity vary depending on the dose, form, route, and duration of exposure, as well as individual differences in metabolism and excretion. Acute poisoning can be divided into two phases. The immediate phase occurs within hours and is characterized by the sudden onset of symptoms such as nausea, vomiting, watery diarrhea, and abdominal pain. These symptoms may lead to low blood pressure, rapid heart rate, decreased urine output, and the potential development of serious cardiac arrhythmias and metabolic acidosis. Rhabdomyolysis and altered mental status, including lethargy, agitation, or seizures, may also occur. Additionally, patients might experience a metallic taste or irritation in the oropharyngeal region. If the patient survives the initial phase, a second or third phase can develop over the following days to weeks. Mental status may deteriorate, with symptoms such as delirium or dulling of consciousness typically appearing 2 to 6 days after exposure. Hematologic abnormalities, particularly pancytopenia, often emerge between 1 and 4 weeks after ingestion of a high dose, reaching their lowest point within 1 to 3 weeks. Cardiovascular effects may include a prolonged QT interval, torsades de pointes, and congestive cardiomyopathy, which can develop from 1 day up to 1 week after exposure. Non-cardiogenic pulmonary edema may also be observed in such cases. Subacute and chronic arsenic poisoning can affect multiple organ systems. Gastrointestinal symptoms such as diarrhea and cramping are common, but individuals may also develop effects on the skin, nervous system, blood, and other organs without prior gastrointestinal symptoms. Liver damage has been reported, including non-cirrhotic periportal fibrosis and portal hypertension, as well as hepatic angiosarcomas. In terms of dermatologic effects, a characteristic pattern of spotted hyperpigmentation and hyperkeratosis of the palms and soles is observed as part of the chronic effects. Arsenic exposure can also cause dermatitis characterized by hemorrhagic vesicles and dry, scaly skin. Neurologically, a sensory-dominant axonal peripheral neuropathy is frequently seen. Delayed brain dysfunction, known as encephalopathy, can occur in cases of acute poisoning, and in chronic exposures, encephalopathy along with peripheral neuropathy are commonly reported. Blood abnormalities include anemia and leukopenia, which typically resolve within weeks to months. Cases of aplastic anemia and agranulocytosis have been documented, and early indicators of arsenic toxicity can include abnormal cell division in the red blood cell lineage, known as erythroid cell breakdown, Chronic ingestion of arsenic is associated with an increased risk of cardiovascular diseases, including heart disease and vascular disorders. One specific disease linked to long-term arsenic exposure, especially in Taiwan, is obliterative arterial disease affecting the arteries of the lower limbs. Chronic occupational exposure to airborne antimony, often associated with arsenic, has been linked to respiratory conditions such as pneumoconiosis, chronic bronchitis, emphysema, pleural adhesions, and general respiratory irritation. These exposures can also lead to restrictive lung disease, sometimes combined with obstructive patterns. Other health effects associated with long-term arsenic exposure include metabolic conditions such as diabetes mellitus and hypertension, as well as an increased risk of various cancers affecting the lung, bladder, skin, kidneys, and liver. Exposure during fetal development or early childhood has been linked to growth retardation, neurotoxicity, birth defects, and increased fetal loss. Diagnosis of arsenic poisoning involves assessing characteristic signs and symptoms, along with a consistent exposure history and confirmatory laboratory findings, while also ruling out other possible diagnoses. Laboratory testing plays a crucial role in diagnosis. The most important test is the urine arsenic concentration. In cases of acute, symptomatic poisoning, the total urinary arsenic level, which includes inorganic arsenic monomethyl arsenic acid and dimethyl arsenic acid, usually exceeds 1,000 micrograms per liter. Typically, the amount excreted in 24 hours reaches into the thousands of micrograms. Speciated arsenic analysis can differentiate between the toxic inorganic forms and the less toxic organic forms commonly found in seafood, which often lead to diagnostic confusion. Blood arsenic levels are also useful, especially when urine samples cannot be obtained, such as in patients who are unable to urinate. In cases of acute poisoning, blood arsenic concentrations tend to be over 100 micrograms per liter. Analysis of hair and nails can provide evidence of past exposure, even months prior, as arsenic becomes incorporated into these tissues during their growth. However, interpreting these results requires caution because external contamination can influence the measurements. Additional findings associated with arsenic poisoning include elevated levels of acid in the blood, which leads to a metabolic acidosis during the early stages. Patients may also display pancytopenia and an increased hematocrit, the latter resulting from hemoconcentration. Rhabdomyolysis, or muscle breakdown, can be indicated by increased levels of creatine phosphokinase in the blood. Urinalysis might reveal proteinuria, hematuria, and pyuria. In neurologic phases of poisoning, cerebrospinal fluid may show a mild elevation of protein. Overall, diagnosing arsenic poisoning requires a comprehensive approach that combines clinical evaluation with laboratory diagnostics, considering both recent and past exposures. Management of arsenic poisoning involves supportive care, decontamination, and chelation therapy. Supportive care includes aggressive intravenous administration of crystalloids to rehydrate the patient and the use of vasopressor drugs to maintain blood pressure. In cases where the patient experiences gastrointestinal fluid loss and hypotension, these measures are especially critical. Additionally, sodium bicarbonate may be necessary to treat severe metabolic acidosis. Gastrointestinal decontamination remains a controversial aspect of treatment because activated charcoal demonstrates poor adsorption of arsenic. Moreover, patients often experience nausea, vomiting, and altered mental status, which can complicate the use of this method. Despite these challenges, activated charcoal is still recommended due to its low risk and its potential to prevent further absorption of arsenic. Whole bowel irrigation can be considered if imaging shows radiopaque material within the gastrointestinal tract. Continuous nasogastric suction may also be employed to remove resecreted arsenic. Regarding chelation therapy, N-acetylcysteine is sometimes considered, although animal studies suggest its potential to increase glutathione and provide a protective effect against arsenic toxicity. There is currently insufficient human data to recommend its use for arsenic poisoning. It is worth noting that N-acetylcysteine has demonstrated effectiveness in experimental chelation therapies for poisoning with chromium and cobalt. Chelating agents play a vital role in treating acute arsenic poisoning. However, their effectiveness is primarily supported by animal studies and limited clinical experience rather than extensive controlled human trials. Prompt administration of these agents, ideally within a few hours of ingestion, significantly improves patient outcomes. One of the earliest chelating agents developed was British anti-leucite, also known as dimercaprol. Originally created as an antidote for leucite, an organoarsenical warfare agent, dimercaprol works by binding to arsenic through its vicinal dithiol groups, forming stable complexes that are excreted from the body. It is supplied in oil for deep intramuscular injection, which can cause pain. Animal studies indicate that this agent increases arsenic levels in the brain. Unlike other chelators such as dimercaptopropane, 1-sulfonate. For severe arsenic poisoning, a typical regimen involves administering doses of 3 to 5 milligrams per kilogram every 4 to 6 hours, with gradually tapering doses. In children who ingest arsenic, treatment with dimercaprol has been associated with fewer deaths, shorter hospital stays, and fewer persistent symptoms compared to untreated groups. A water-soluble analog of dimercaprol, known as dimercaptosuccinic acid or succimer, offers advantages including a higher therapeutic index and the convenience of oral administration. This chelating agent has been used since 1965 in China and the Soviet Union for arsenic toxicity. Animal studies demonstrate that dimercaptosuccinic acid can improve the lethal dose 50% or LD50 of arsenic, and unlike dimercaprol, it does not cause redistribution of arsenic to the brain. Another water-soluble analog is dimercaptopropane 1-sulfonate, also called unithiol or dimaval. It has a higher therapeutic index and potency ratio in experimental acute arsenic poisoning than dimercaprol. This agent can be administered intravenously, facilitating faster delivery, which is especially important in patients experiencing hypotension or shock. Dimercaptopropane 1-sulfonate is more effective than dimercaprol in mobilizing arsenic from tissues such as the brain. It forms a complex with arsenic known as the dimercaptopropane 1-sulfonate methyl arsenic 3 complex, which is the only intact arsenic chelator complex ever isolated in human urine. Additionally, this chelating agent increases urinary excretion of zinc. In choosing the appropriate chelating agent, dimercaptopropane 1-sulfonate and oral dimercaptosuccinic acid are increasingly favored over dimercaprol due to their improved safety profiles, higher therapeutic indices, and ease of administration. Dimercaptol may still be considered in the early stages of acute arsenic poisoning involving arsenic trioxide because of its lipid-soluble properties. The decision to use chelating agents in cases of subacute or chronic arsenic toxicity depends on the patient's clinical condition and deterioration. Cobalt, derived from the German word kobold, meaning goblin, has a complex toxicological profile within the broader context of heavy metal poisoning. It is often associated with both historical and contemporary occupational and environmental exposures. Its clinical effects are less thoroughly defined than those of more common transition metals such as lead-mercury and arsenic. Historically, miners exposed to cobalt-containing or specifically cobaltite became ill. However, this illness was likely more attributable to arsenic exposure rather than cobalt itself. The discovery of cobalt in 1753 by George Brandt was an effort to demonstrate that an element other than bismuth was responsible for the blue hue in glass. In the past, cobalt chloride was combined with iron salts to treat anemia in the 1950s because of its ability to stimulate the production of red blood cells. Despite known adverse effects, some physicians continued this practice until at least 1976. Additionally, cobalt-60, a radioactive isotope, was once used in cancer radiotherapy. During the period from the 1950s to the 1970s, notable epidemics of cardiomyopathy and goiter occurred. These were termed Beer-Dringer's cardiomyopathy and cobalt-induced goiter, and were linked to the addition of cobalt sulfate as a foam stabilizer in beer. These epidemics ceased once cobalt sulfate was discontinued for this aesthetic purpose. Currently, sources of cobalt exposure include items such as chemistry sets, weather indicators, antiquated anemia therapies, cement, fly ash, dyes, mineral wool, asbestos, molds for ceramic tiles, and production of tungsten carbide used in the wood industry. Other sources comprise mining activities, porcelain paint, orthopedic implants, dental hardware, nutritional supplements, and the formation of cemented tungsten carbide, also known as hard metal. This last process involves sintering powdered cobalt and tungsten at high temperatures, which significantly increases workplace cobalt concentrations and is associated with pulmonary toxicity known as hard metal disease. Occupational studies and preventive measures have since reduced acceptable cobalt exposure levels in workplaces. More recently, concern has shifted to a condition called cobaltism, linked to metal-on-metal orthopedic implants. In terms of chemistry and toxicokinetics, cobalt exists in elemental form, inorganic salts, and organic forms. Inorganic cobalt salts, such as cobalt chloride and cobalt sulfate, were historically used in anemia treatment and were implicated in epidemics related to beer consumption. Organic cobalt compounds, like vitamin B12, are considered of low toxicity because they are poorly absorbed orally and eliminated quickly through the kidneys. In general, inorganic salts are more toxic than organic forms. Animal studies show that oral absorption of cobalt oxides, salts, and metal is highly variable, ranging from 5 to 45% of bioavailability. Human studies indicate that iron deficiency and iron overload, as seen in hemochromatosis, can enhance absorption of cobalt through the small intestine. Inhaled cobalt oxide is approximately 30% bioavailable. The distribution of cobalt in the body is influenced by plasma proteins, primarily albumin and transferrin, which also bind iron. This explains its erythropoietic effect. Cellular uptake of cobalt is mediated by specific transporters, including the P2X7 transporter and active divalent metal transporter 1. Most absorbed cobalt, between 50 and 88%, is eliminated through the kidneys, with the remainder excreted via feces. Acute increases in inorganic cobalt concentrations cause increased renal elimination. However, this rate rapidly decreases despite the presence of a large body burden. Cobalt is a toxin that affects multiple organs. Its toxicity arises from several mechanisms. One mechanism involves enzyme inhibition, where divalent cobalt ions interfere with enzyme systems and disrupt the initiation of protein synthesis. For example, cobalt ions can displace magnesium ions from the cofactor site of an enzyme called polynucleotide phosphorylase, which is essential for RNA synthesis. This displacement reduces the enzyme's activity by 50% in laboratory settings. Another mechanism concerns cobalt's interaction with other metal cations such as magnesium, manganese, zinc, and calcium, which may contribute to its toxic effects. Additionally, cobalt induces oxidative stress through redox cycling, leading to pulmonary and neurotoxicity. It can accept and transfer electrons to oxygen molecules, forming superoxide free radicals. This process results in an accumulation of harmful free radicals, especially in the lungs where oxygen is abundant. Furthermore, cobalt ions can bind to sites on iron-binding proteins like transferrin. This binding can impair oxygen transport to kidney cells and influence erythropoietin production, a hormone involved in red blood cell formation. Interestingly, these properties partly explain why cobalt was historically used in the treatment of anemia, as it can influence iron availability and erythropoiesis. The minimum acute toxic dose of cobalt salts is not well defined, and effects can vary significantly among patients. For instance, individuals suffering from Beard-Dringer's cardiomyopathy have been known to consume an average of 6 to 8 milligrams of cobalt sulfate daily over several weeks or months. These patients have developed acidemia, cardiomyopathy, shock, and ultimately death. Interestingly, infants treated for anemia with a much higher daily dose of an iron-cobalt formulation, which included 40 milligrams of cobalt chloride and 75 milligrams of ferrous sulfate for 3 months, did not develop toxicity. This suggests that the causality of cobalt toxicity might be multifactorial, potentially involving factors such as alcohol metabolism or nutritional status. Cobalt poisoning can impact multiple organ systems. Cardiovascular effects, particularly cardiomyopathy, are prominent. The condition known as beer-drinker's cardiomyopathy was linked to cobalt sulfate found in beer. Although often associated with chronic alcoholism and malnutrition, acute cardiac toxicity from cobalt poisoning has also been reported. Additionally, some patients with cobalt released from arthroprosthetic devices develop cardiomyopathy. The endocrine system can also be affected by cobalt exposure. Both acute and chronic exposures may cause thyroid hyperplasia and goiter, which can sometimes lead to clinical hypothyroidism and, in severe cases, airway obstruction. Occupational exposure to cobalt can alter thyroid function, although these effects are less common in environments with limited exposure. Hematologically, cobalt stimulates the production of red blood cells, which can result in polycythemia. Animal studies have demonstrated transient hemolysis, methemoglobinemia, and the presence of methemoglobin in urine following cobalt exposure. Gastrointestinal distress, including nausea, vomiting, and abdominal pain, can occur after ingestion of cobalt salts. Neurological effects from acute oral cobalt exposure may include decreased proprioception, impaired function of the eighth cranial nerve, and nonspecific peripheral nerve symptoms. Patients with cobalt released from prosthetic devices may experience seizures, cerebellar deficits, retinopathy, hearing loss, cognitive impairments, and peripheral neuropathy, sometimes correlating with elevated cobalt concentrations in cerebrospinal fluid. Chronic inhalation of cobalt particles can lead to a condition known as hard metal disease, characterized by irritation of the upper respiratory tract, exertional shortness of breath, dry cough, wheezing, and interstitial lung disease that ranges from alveolitis to progressive fibrosis. Histopathological examination often shows multinucleated giant cells and interstitial pneumonitis. Occupational asthma related to cobalt hypersensitivity has also been reported. Symptoms generally improve after cessation of exposure, but not universally. Dermatologically, allergic contact dermatitis has been linked to cobalt exposure from consumer products such as piercings, tattoo inks, plastics, and clothing dyes. This hypersensitivity reaction appears to be independent of nickel allergy. Regarding renal effects, there is a single report of reversible acute kidney injury associated with chronic cobalt administration for anemia. Animal models suggest that cobalt can cause cellular changes in kidney tissue, but human studies of workers exposed to cobalt or patients with cobalt-containing hip replacements show little significant impact on kidney function. In reproductive health, studies in mice indicate that chronic cobalt exposure impairs sperm production and reduces fertility. However, there are no reported cases linking cobalt exposure in humans to birth defects or impaired fertility. Concerning carcinogenicity, the International Agency for Research on Cancer classifies cobalt metal without tungsten carbide, cobalt sulfate, and other soluble cobalt compounds as possibly carcinogenic to humans. Cobalt metal associated with tungsten carbide is considered probably carcinogenic. Exposure to cobalt in the lungs may increase the risk of lung cancer, although these studies are often complicated by exposure to other substances. Body fluid cobalt concentrations are not readily available for emergent clinical care. Adjunctive tests that support a diagnosis of cobalt toxicity include complete blood count, respiratory count, erythropoietin concentration, and thyroid-stimulating hormone concentration. These tests reflect exposure levels or potential toxic effects. For arthroprosthetic cobaltism, imaging tests such as plain radiographs and magnetic resonance imaging can detect local reactions or pseudotumors. However, these imaging techniques do not diagnose systemic toxicity but rather indicate risk. Evaluation of cobalt in urine is generally most appropriate for assessing cobalt elimination, since most absorbed cobalt is eliminated through the kidneys. Nonetheless, interpretation can be complicated by variable elimination patterns, which tend to be rapid initially and slow with prolonged exposure, as well as the presence of organic cobalt derived from vitamin B2. Speciation of cobalt, which involves analyzing the ratio of inorganic to organic cobalt, may provide valuable insight for evaluating individuals exposed to cobalt in occupational settings. Whole blood cobalt concentrations are typically considered more accurate for reflecting the total body burden of cobalt. Normal serum concentrations generally range from 0.1 to 1.2 micrograms per liter. In asymptomatic patients with cobalt-containing hip implants, peak serum levels have not exceeded 11.5 micrograms per liter. Some guidelines recommend suspecting cobalt poisoning associated with joint implants when blood concentrations exceed 10 micrograms per liter. Reported serum cobalt concentrations in symptomatic cases of cobalt poisoning related to joint implants have been reported to vary widely from 23 to 1,085 micrograms per liter. Normal reference values for cobalt in urine are between 0.1 and 2.2 micrograms per liter. Acute management of cobalt exposure requires aggressive therapy. In the absence of specific studies on cobalt, principles of decontamination used for other metals are applicable. Whole bowel irrigation is a reasonable approach for removing radiopaque solid forms of cobalt, especially prior to endoscopic or surgical procedures. However, activated charcoal may hinder visualization during surgical removal. Chelation therapy is generally considered after the gastrointestinal source of cobalt has been removed. Regarding chelation therapy, the available data are limited to animal studies and human case reports. Early research indicated that proteins containing sulfur could decrease cobalt toxicity. In animal models, substances such as N-acetylcysteine, succimer, and calcium disodium ethylenediamine tetrachic acid facilitated the elimination of cobalt. N-acetylcysteine and glutathione were also found to reduce the tissue burden of cobalt, particularly in the liver and spleen. Among chelators tested, calcium disodium ethylenediamine tetrachic acid and diethylenetrylamine pentacetic acid were most effective in reducing mortality in animal studies. Dimercaprol, however, was ineffective at chelating cobalt ions bound to alpha-ketoglutarate, and despite this evidence, it has occasionally been used based on a case report. In human cases, intravenous calcium disodium ethylenediamine tetrachic acid has been shown to enhance renal cobalt elimination and reduce serum cobalt levels, such as in a child who ingested cobalt magnets. Both calcium disodium ethylenediamine tetrachic acid and N-acetylcysteine have been used in cases of cobalt-related joint prosthetic disease, with mixed results in reducing cobalt levels and alleviating symptoms. Based on available human case reports, animal studies, and safety data, calcium disodium ethylenediamine tetrachic acid and N-acetylcysteine are considered reasonable choices for chelation therapy. Chelation is recommended for patients exhibiting signs of toxicity affecting vital organs, such as acidemia and cardiac failure. For example, a regimen used in lead poisoning, 1,000 milligrams per square meter per day by continuous infusion over 5 days, is recommended when using calcium disodium ethylenediamine tetrachic acid. Treatment for arthroprosthetic cobaltism emphasizes early clinical suspicion and timely prosthetic revision, as these are crucial for effective management. It is important to note that chelation therapy may not completely eliminate significant quantities of cobalt when a large metal reservoir is present. In cases of occupational or chronic exposure, prevention is the key. Measures such as improved industrial hygiene, proper skin and respiratory protection, and maintaining personal hygiene are vital. Removing individuals from the source of exposure often results in an improvement in symptoms. Mercury is a metal known for its widespread toxicity, affecting multiple organ systems. Its various forms each present distinct toxicologic profiles, routes of exposure, and treatment considerations. Understanding these distinctions is crucial for accurately diagnosing and managing mercury poisoning. Mercury exists in several physical and chemical forms. Elemental mercury, inorganic mercury salts, such as mercurous ion and mercuric ion, and organic mercury compounds, including methylmercury, ethylmercury, and dimethylmercury. Elemental mercury, also known as metallic mercury or quicksilver, is a silvery liquid at room temperature with a high vapor pressure, meaning it readily evaporates. Most intoxications from elemental mercury arise from occupational exposures in mining, chlor-alkali plants, dental amalgam preparation, and the manufacturing or repair of instruments like thermometers and barometers. Accidental ingestion of small amounts from broken oral thermometers is common in children, but is typically non-toxic due to poor gastrointestinal absorption. However, aspiration, subcutaneous deposition, or direct intravenous embolization can lead to slow absorption and toxicity. While controversial, scientific evidence generally refutes that mercury vapors from dental amalgam fillings pose health risks or cause clinical poisoning. Inorganic mercury salts, such as mercurochloride, can cause irritation, vesiculation, and corrosion of the skin, and corrosive damage upon ingestion. Historically, inorganic mercury compounds were used as antibacterials, topical antiseptics, in skin lightening products, paints, tattoo dyes, diuretics, and cathartics. Unintentional poisoning has occurred from stool preservatives, non-prescription medications, and Ayurvedic medicines. Organic mercury's most prevalent environmental form is methylmercury, a short-chain alkyl compound. Organic mercury compounds have been used as biocides, fungicides, pesticides, seed dressings, antiseptics, and medicinal preservatives such as thimerosal. Major poisonings like those in Minamata Bay, Japan, and Iraq occurred from consuming contaminated seafood or grain treated with methylmercury. Dimethylmercury is an extremely toxic organic mercurial that has caused delayed, fatal neurotoxicity from minute dermal exposures. Thimerosal, an aryl mercury compound, has been widely used as a pharmaceutical preservative, and while generally considered safe, excessive therapeutic application or intentional overdose can lead to toxicity and death. The toxicokinetics of mercury vary significantly depending on its form. Elemental mercury is primarily absorbed through inhalation of vapors, which are highly lipid-soluble and quickly diffuse into the bloodstream. Once inside cells, elemental mercury is oxidized to mercurous and mercuric ions. These ions are less lipophilic, leading to their retention and accumulation, particularly in the kidneys and brain. Mercury is eliminated from the body via expired air, urine, and feces, with about 10% of inhaled mercury being expelled within the first few days. The entire body's half-life of elemental mercury is approximately 60 days, though it can range from 35 to 90 days. Inorganic mercury salts, such as mercurochloride, are less readily absorbed, with roughly 10% of ingested amounts being absorbed. Absorption increases if the gastrointestinal mucosa is damaged. Monovalent mercurous salts tend to be less soluble, and absorption through the skin depends on the vehicle of exposure. Mercuric ions have low lipid solubility, making it difficult for them to cross the blood-brain barrier. However, with chronic exposure and slow elimination, these ions can accumulate in the central nervous system. The highest concentrations of mercuric ions are found in the kidneys. Excretion mainly occurs through feces and urine, primarily via tubular and biliary secretion. The half-life of inorganic mercury in the body ranges from 30 to 60 days, averaging around 40 days, but in the brain, it can persist for several years to decades. The placenta acts as an effective barrier to mercuric ions. Organic mercury, such as methylmercury, is readily absorbed and tends to accumulate significantly in red blood cells, with an approximate ratio of 10 to 1 compared to plasma. It easily crosses the blood-brain barrier and the placental barrier due to its lipophilicity. In the body, methylmercury is slowly converted into inorganic mercury within the brain and kidneys. Its elimination predominantly occurs through fecal excretion, often involving enterohepatic recirculation. Hair analysis can reveal methylmercury levels that are up to 250 times higher than those in whole blood. The half-life of methylmercury in the body is about 70 days, with a blood half-life of approximately 44 days. Other mercury compounds, such as aryl and long-chain alkyl mercury compounds, contain less stable carbon-mercury bonds, which can release inorganic mercuric ions. As a result, their toxicity profile eventually resembles that of inorganic mercury poisoning. Mercury's widespread toxicity arises from its strong tendency to covalently bind to sulfhydryl groups on enzymes and proteins, replacing hydrogen ions and reacting with phosphoryl carboxyl and amide groups. This interaction results in extensive dysfunction of enzymes, transport mechanisms, cell membranes, and structural proteins. When mercury vapor contacts the airways, it can cause damage such as exudative alveolar and interstitial edema, as well as desquamation of bronchiolar epithelial cells. Once absorbed, mercury is oxidized into mercuric ions, which then circulate systemically and cause toxicity similar to inorganic mercury. Inorganic mercury salts primarily exert their toxic effects through high-affinity binding to thiol groups, such as glutathione and cysteine. Divalent mercury tends to accumulate in the kidneys, where it induces the production of metallothionein, a protein that can detoxify mercury by forming non-toxic complexes. Divalent mercury ions can also generate oxidant-free radicals, leading to oxidative stress, lipid peroxidation, and dysfunction of mitochondria. These processes contribute to multiple organ failure. Direct injury to the epithelial cells of the proximal renal tubules results in renal tubular necrosis, while immune mechanisms are implicated in the development of membranous glomerulonephritis. Organic mercury, such as methylmercury, also exhibits a high affinity for sulfhydryl groups but does not induce metallothionein production. It causes severe damage to the cerebral and cerebellar cortex, resulting in neuronal loss, proliferation of glial cells, formation of microcavities, vascular congestion, and hemorrhage. In the developing fetal brain, methylmercury inhibits neuronal cell division and migration, leading to widespread damage. The neuropathological changes caused by methylmercury differ from those seen with elemental or inorganic mercury. While the latter tend to preserve neuronal architecture, they cause a reduction in the number of Purkinje and granular cells in the cerebellum. The clinical manifestations of mercury exposure vary significantly depending on the form of mercury involved. Elemental mercury, when inhaled acutely, can cause a condition known as mercury fume fever. This condition is characterized by symptoms such as cough, chills, fever, headache, shortness of breath, a metallic taste, gastrointestinal complaints including nausea, vomiting, and diarrhea, as well as salivation, sweating, weakness, and visual disturbances. In cases of severe exposure, individuals may develop necrotizing bronchitis, bronchiolitis, pneumonitis, pulmonary edema, respiratory failure, and even death. There is also a risk of long-term pulmonary fibrosis. Survivors of acute inhalation may experience symptoms similar to chronic inorganic mercury poisoning, which include renal toxicity, inflammation of the gums, and neurological symptoms like intention, tremor, and irritability, excitability, anxiety, or shyness. Intravenous injections of mercury can lead to pulmonary and systemic microembolisms. Inorganic mercury salts, when ingested acutely, cause immediate caustic effects. These effects can range from severe gastrointestinal irritation to ulceration, necrosis, perforation, and acute hemorrhage, which may result in hypovolemia, shock, electrolyte imbalances, and acute renal tubular necrosis. Common signs include grayish discoloration of mucous membranes and a metallic taste. Chronic inorganic mercury poisoning, which may stem from prolonged inhalation of elemental mercury or the dissociation of organic mercurials, primarily affects the kidneys, leading to proximal tubular dysfunction, proteinuria, and nephrotic syndrome. It can also present with gastrointestinal and neurological symptoms such as a metallic taste, inflammation of the gums, excessive salivation, tremors, mental fatigue, and irritability. An additional hypersensitivity reaction, known as the condition of the skin, presents as a pinkish rash on the palms, soles, and face. Organic mercury compounds are associated with profound neurological effects, often with a delayed onset of weeks to months following exposure. Symptoms include abnormal sensations such as paresthesias, coordination problems like ataxia, visual impairments including tunnel vision and blindness, hearing disturbances, difficulty speaking, tremors, movement disorders, mental slowing, and dementia. Severe cases can be fatal. Prenatal exposure to methylmercury, as evidenced in Minamata disease, can lead to severe developmental delays, physical deformities, mental retardation, and spasticity in infants, even when maternal symptoms are mild. Dimethylmercury has been known to cause delayed and fatal neurotoxicity. Ethylmercury exposure may result in gastrointestinal symptoms, skin rash, kidney failure, and nerve damage that resembles chronic inorganic mercury poisoning. The diagnosis of mercury poisoning relies on demonstrating the presence of mercury in blood, urine, or tissues in conjunction with consistent clinical signs and exposure history. It is crucial to use mercury-free collection materials, which are usually provided by the laboratories conducting the tests. Whole blood samples should be collected in trace element tubes, while 24-hour urine collections are preferred over spot samples and should be stored in acid wash containers. There is often a poor correlation between mercury levels in blood or urine and the clinical manifestations of poisoning. Mercury does not have a useful role in human physiology. Urine testing is most effective for monitoring exposure to elemental and inorganic mercury, as well as for assessing the efficacy of chelation therapy. Typically, urine mercury levels below 20 to 25 micrograms per liter are considered normal, although levels above 10 micrograms per liter are rare in unexposed individuals. Levels exceeding 100 micrograms per liter are associated with minor neurological signs, and levels above 300 micrograms per liter indicate overt toxicity. Blood mercury levels reflect recent exposure to elemental and inorganic mercury, but this measure becomes less reliable over time as mercury redistributes within the body. For organic mercury, such as methylmercury, whole blood levels are more accurate indicators of acute exposure and total body burden because of its high concentration in red blood cells. Normal whole blood mercury levels are typically less than 10 micrograms per liter, although individuals who consume seafood regularly may have higher levels. Mercury can accumulate in hair, but its reliability as a marker of overall body burden is questionable. Hair mercury levels primarily reflect past exposure and can be influenced by environmental mercury, making this test less definitive for current body burden assessments. Depending on the clinical scenario, additional diagnostic tests may be necessary. These include arterial blood gas analysis, serum chemistry tests to evaluate kidney and liver function, a complete blood count, and urinary markers indicative of renal damage. Radiographs may reveal radiopaque mercury deposits following ingestion or exposure through intravenous or subcutaneous routes. Management of mercury poisoning involves immediate actions such as the termination of exposure, decontamination procedures, and supportive care. When skin or eye contact occurs, it is essential to remove contaminated clothing and flush the affected areas thoroughly with water. In cases of ingestion of corrosive inorganic mercury, gastric lavage is contraindicated because it may cause perforation. Activated charcoal has limited ability to bind metallic compounds. However, it may be justified in cases of inorganic mercury due to the potential for serious complications and the significant adsorption capacity of charcoal. Whole bowel irrigation with polyethylene glycol can help remove residual radiopaque material from the gastrointestinal tract. For subcutaneous or intravenous deposits of elemental mercury, surgical excision is indicated if the deposits are accessible. Organic mercury exposure is often chronic and gastrointestinal decontamination is generally ineffective. Nonetheless, aggressive treatment may be necessary following acute ingestions or dermal exposure. Extracorporeal removal techniques such as hemodialysis are typically ineffective at removing mercury from the body because of its binding properties and ability to redistribute within tissues. However, hemodialysis may be required if renal failure develops. Plasma exchange has shown limited effectiveness in treating mercury poisoning. Chelation therapy involves the use of chelating agents that contain thiol groups, which compete with the body's endogenous sulfhydryl groups to bind mercury. This treatment is typically indicated in cases of significant mercury exposure accompanied by severe poisoning symptoms or a large mercury burden in the body. However, provocative chelation is not recommended as a diagnostic tool. Regarding elemental and inorganic mercury poisoning, dimercaprol, historically a primary chelating agent, is used to mobilize mercury from the kidneys and to protect against kidney damage. It is administered via intramuscular injection. Nevertheless, this medication is contraindicated in cases of organic mercury poisoning and exposure to elemental mercury vapor, as it can lead to the redistribution of mercury to the brain, potentially exacerbating neurotoxicity. The text describes 2 chelators used in mercury poisoning treatment. Currently, the preferred chelator in cases of elemental and inorganic mercury poisoning, particularly in Europe, is 2,3-dimercapto-1-propanesulfonate. This compound, a water-soluble analog of dimercaprol, can be administered either intravenously or orally. It has a better side effect profile than dimercaprol and has demonstrated effectiveness in reducing body mercury burden and safeguarding against renal damage. Importantly, it does not appear to cause redistribution of mercury to the brain. Treatment regimens may include an initial intravenous dose followed by oral medication. Another chelating agent is 2,3-dimercaptosuccinic acid, better known as Succimer. It is an orally active water-soluble analog of dimercaprol. Succimer is effective in decreasing body mercury levels and protecting kidney function. It is often recommended as an oral alternative to dimercaprol, especially when patients are able to take oral medications. This is particularly applicable in cases of chronic poisoning or less severe acute cases, owing to its improved side effect profile. Similar to the first chelator, Succimer does not seem to facilitate the redistribution of mercury to the brain. Dipenicillamine is an orally administered monothiol that has limited usefulness due to potential adverse effects such as gastrointestinal distress, rashes, leukopenia, thrombocytopenia, and proteinuria. An investigational analog of dipenicillamine is N-acetyl D-L-penicillamine, which is considered more effective for mercury chelation because of its greater stability. In cases of organic mercury poisoning, the neurotoxicity caused by methylmercury is largely resistant to treatment. Therefore, early recognition and prevention of neurotoxicity are crucial. Succimer is regarded as the most reasonable treatment option for methylmercury poisoning because of its low toxicity and reported efficacy in animal trials. It has shown the ability to decrease brain mercury levels and increase urinary excretion of mercury in mice. Dimercaprol is not recommended for treating organic mercury poisoning because animal studies suggest it may increase mercury mobilization into the brain, potentially worsening neurotoxicity. The effectiveness of drugs such as dimercaprol, 2,3-dimercapto, 1-propanesulfonic acid, and dimercaptosuccinic acid in organic mercury poisoning has yielded conflicting results. These discrepancies may depend on the timing of chelation therapy. For example, aggressive chelation with dimercaptosuccinic acid was ineffective in a patient experiencing rapid neurological deterioration due to dimethylmercury, which suggests a limited capacity to chelate mercury deposited in neuronal tissue or to reverse existing damage. Regarding N-acetylcysteine, some studies have investigated its role in mercury detoxification. Animal research shows that it can significantly increase methylmercury excretion in urine and mobilize mercury from tissues, including the brain. However, its efficacy in treating chronic methylmercury poisoning in humans has not yet been established. Understanding the multifaceted nature of heavy metal poisoning is crucial for healthcare professionals. One such heavy metal, thallium, exemplifies how its unique chemical properties influence its toxicokinetics, clinical manifestations, and management within the broader field of toxicology. Thallium, with an atomic number of 81, is situated on the periodic table between mercury and lead. While elemental thallium is essentially non-toxic, its salts in the univalent and trivalent forms are highly toxic. Naturally, thallium occurs in materials such as granite, shale, volcanic rock, and pyrites. Additionally, it can be recovered as flue dust from smelters that process metals like iron, lead, cadmium, and copper. Historically, salts containing thallium had various medicinal and commercial uses during the early 20th century. They were employed to treat medical conditions such as syphilis, gonorrhea, and tuberculosis. One notable usage was as a hair removal agent for scalp ringworm. Although the typical oral dose to treat ringworm ranged from 7 to 8 milligrams per kilogram of body weight, the fatal doses varied widely from 6 to 40 milligrams per kilogram. This narrow margin of safety led to many cases of severe poisoning, commonly known as thallium toxicosis, with reports of nearly 700 cases and 46 fatalities. Thallium sulfate, which is odorless, tasteless, and highly toxic, also became available commercially as a pesticide for rodents. Although the United States banned the use of thallium-based rodenticides and pesticides in 1965, similar restrictions were implemented in other countries. Despite these bans, sporadic cases of thallium poisoning still occur. These cases often result from malicious poisoning, ingestion of stored rodenticide products from before the ban, or contamination of herbal remedies and illicit drugs such as heroin, opium, and cocaine. Occupational exposure to significant quantities of thallium salts is rare, but well documented. Such exposures typically occur in industries like semiconductor manufacturing, optical device production, thermometer manufacturing, and photoelectric cell creation. It is important to note that small amounts of radioactive thallium used in medical imaging procedures pose no risk of toxicity. Thallium is quickly absorbed into the body through all routes of exposure, including inhalation, ingestion, and absorption through intact skin. The oral bioavailability of thallium exceeds 90%. Once absorbed, thallium rapidly redistributes within cells, demonstrating a large estimated volume of distribution ranging from 3 to 10 liters per kilogram. It tends to concentrate in highly perfused tissues such as the kidneys, liver, intestines, lungs, heart, brain, and muscles. In animal studies, the highest concentrations of thallium are often found in the kidney. Thallium's toxicokinetics is commonly described using a three-phase model. The first phase occurs within the first 4 hours and involves rapid distribution of thallium to the central compartment and well-perfused peripheral organs. The second phase takes place between 4 and 24 hours, with the distribution of thallium to a slow exchange compartment, including the brain, which contributes to its neurotoxicity. The elimination phase involves the primary excretion of thallium through feces, accounting for 51.4%, and through urine, accounting for 26.4%. During this phase, thallium undergoes significant enterohepatic recirculation, where it is secreted into the intestine via bile but then reabsorbed. This process prolongs its terminal half-life to approximately 2.2 days. Unlike many other metals, thallium does not have a major anatomically defined reservoir, which results in relatively short elimination half-lives in humans who have been poisoned. The mechanisms underlying thallium toxicity are complex and involve multiple factors. Thallium's primary mode of action is its ability to mimic potassium ions, owing to their similar ionic radii. Thallium has an ionic radius of 1.44 A, while potassium's is 1.33 A. This similarity allows thallium to interfere with processes that depend on potassium. For instance, thallium can substitute for potassium in critical cellular functions, such as the sodium-potassium ADPase pump. Interestingly, thallium binds to this pump with a 10-fold higher affinity than potassium. At higher concentrations, thallium inhibits the pump, disrupting cellular ion balance, but at very low concentrations, it may actually activate the pump. Thallium inhibits enzymes that contain sulfhydryl groups by binding to their SH groups. This action affects critical metabolic enzymes such as lactate dehydrogenase and phosphoglycerate kinase. Additionally, thallium disrupts mitochondrial energy production by uncoupling oxidative phosphorylation and inhibiting enzymes like pyruvate kinase and succinate dehydrogenase. These effects lead to a reduction in adenosine triphosphate production, oxidative stress, and mitochondrial swelling and vacuolization. The oxidative damage caused by thallium can result in the accumulation of lipid peroxides, especially in the cerebellum, where they appear as dark pigmented areas. Notably, N-acetylcysteine, an antioxidant that increases glutathione stores, has been shown to fail in protecting against thallium toxicity in an animal model. There is also a hypothesis that thallium causes a functional deficiency of riboflavin because it forms an insoluble complex with this vitamin. However, animal studies have not demonstrated that riboflavin supplementation prevents or reduces the toxicity caused by thallium. Furthermore, thallium can induce lipid peroxidation in different regions of the rat brain. Thallium poisoning can cause a variety of clinical manifestations because it spreads widely throughout the body. The classic triad of findings includes acute gastroenteritis, polyneuropathy, and hair loss. The timing and order of these symptoms can differ based on how severe and long-lasting the exposure was, with some patients not showing symptoms until days or even weeks after ingesting thallium. In the early phase, typically within hours of exposure, gastrointestinal issues are common. These can include nausea, vomiting, abdominal pain, general gastroenteritis, diarrhea, or constipation. More severe problems like vomiting blood, bloody diarrhea, or sores on the mucous membranes can also occur. Autopsy results might reveal stomach bleeding and widespread necrotizing mucositis. Oral symptoms can involve inflammation of the mouth and a bluish tint to the gums. Constipation is thought to happen because of reduced intestinal movement and contractions, which is believed to be due to direct involvement of the vagus nerve. In the intermediate phase, which spans hours to weeks, cardiovascular effects are frequently observed. These include sinus tachycardia, hypertension, and chest pain. Less commonly, bradycardia, ventricular arrhythmias, and atrial fibrillation can occur, even in individuals without structural heart disease. The cardiac effects are likely multifactorial, potentially involving vagal nerve dysfunction. A persistent and pronounced tachycardia is associated with a poor prognosis. The neurologic effects during the intermediate phase are prominent and can sometimes be the first indication of toxicity. Patients typically experience painful sensations called paresthesias, which usually affect the distal parts of the limbs, especially the lower extremities initially. Motor weakness may develop subsequently, also starting in the distal regions. Early in the progression, reflex responses are generally preserved, which helps differentiate this condition from Guillain-Barré syndrome. Muscle wasting can become noticeable weeks after ingestion. Cranial nerve palsies have been reported, presenting with varied symptoms such as ptosis, which is often asymmetric, speech difficulties, swallowing problems, a weakened gag reflex, double vision, and facial weakness. Notably, cranial nerves 1, 5, and 8 are usually not affected. Additional neurological findings include ataxia, tremors, myoclonus, blindness, and other visual disturbances. Chronic toxicity can also lead to optic neuropathy and paralysis of the eye muscles, known as ophthalmoplegia. Neuropsychiatric symptoms resembling psychosis or delirium are also documented. In severe poisoning cases, late-stage symptoms such as encephalopathy, coma, and seizures can occur and are associated with a poor prognosis. Pathological examination of affected nerves reveals axonal degeneration and varying degrees of damage to the myelin sheath in peripheral nerve fibers, while the spinal cord's nerve fibers typically remain unaffected. In chronic cases, memory loss and dementia may persist even after the initial toxicity has subsided. The dermatologic effects of thallium poisoning typically appear in the late phase, which occurs 2 to 4 weeks after exposure. These effects include highly characteristic alopecia, which can sometimes be permanent along with acne, palmar erythema, and dry, scaly skin. Additionally, mesalines, which are transverse white bands that appear on the nails, generally develop within this 2 to 4 week period. Regarding renal effects, thallium poisoning is associated with relatively milder kidney damage compared to other heavy metals. Patients may experience proteinuria, leukocyturia, and erythrocyturia, indications of abnormal presence of proteins, white blood cells, and red blood cells in the urine, without a significant overall loss of kidney function. The cellular damage is primarily localized to the thick ascending limb of the loop of Henle in the kidney, with the glomeruli usually spared. Other possible findings in thallium poisoning include less common but notable effects such as damage to the liver, a condition called hepatotoxicity, metabolic acidosis characterized by an excess of chloride ions, anemia, and a reduction in platelet count known as thrombocytopenia. Thallium readily crosses the placenta and is a potent teratogen in animal models, causing reduced body weight, hydronephrosis, and impaired skeletal development. Human reports of prenatal thallium exposure are rare, but reported outcomes range from no apparent abnormalities to severe effects such as imperforate anus, cryptorchidism, and long-term psychomotor retardation. An association between prenatal thallium exposure and low birth weight has been demonstrated. Fetal outcome is influenced by the trimester of pregnancy and maternal toxicity, with exposure during organogenesis potentially leading to permanent injury. Children exposed closer to term may be born with overt toxicity, including alopecia, dermatitis, nail growth disturbances, and permanent CNS injury. Nursing is not recommended as thallium transfers into breast milk. Thallium poisoning should be considered in any patient presenting with the classic triad of gastroenteritis, ascending polyneuropathy, and hair loss. The diagnosis is definitive when elevated thallium concentrations are detected in bodily fluids. Typically, a 24-hour urine collection is used where normal levels are usually less than 1 microgram per liter or 5 micrograms per liter. Other bodily fluids that can be tested include blood, hair, nails, feces, and saliva. However, qualitative point-of-care urine spot tests are not recommended because they can produce false negatives and involve the use of hazardous chemicals. Nerve conduction studies can help confirm the presence of neuropathy. Due to the broad range of possible causes for these symptoms, a high level of clinical suspicion is essential. This is particularly important because the differential diagnosis can include other heavy metal poisoning such as arsenic, lead, and selenium, Guillain-Barré syndrome, chronic alcoholism, poisoning from organophosphates, and nutritional deficiencies. The treatment of thallium poisoning primarily focuses on enhancing elimination from the body, as there are no known therapies that directly counteract its biological effects. Due to the rarity of this poisoning, data from controlled human trials are scarce. In cases of gastrointestinal decontamination, orogastric or nasogastric lavage is recommended for patients who present within 1 to 2 hours of ingestion and have not experienced spontaneous vomiting, especially in cases of substantial ingestion. Activated charcoal is highly effective in this context, as thallium salts are significantly adsorbed to it in laboratory settings. Because thallium undergoes extensive enterohepatic recirculation, activated charcoal can be useful both to prevent absorption if administered shortly after ingestion and to promote elimination after absorption has occurred. Multiple doses of activated charcoal have been shown in animal models to increase fecal elimination of thallium and improve survival rates. If Prussian blue is unavailable, activated charcoal can be used as an alternative. For larger ingestions or when radiopaque material is visible in the gastrointestinal tract, whole bowel irrigation using polyethylene glycol electrolyte lavage solution is recommended. Additionally, laxatives such as oral mannitol may be administered alongside initial doses of activated charcoal to address the common issue of constipation associated with severe thallium toxicity. Ferric cyanophorate, also known as Prussian blue, is the most widely recommended agent for increasing the excretion of thallium through feces. It has been approved by the United States Food and Drug Administration for treating thallium poisoning as well as radioactive cesium poisoning. Prussian blue functions as an ion exchanger for univalent cations within the gastrointestinal lumen. It prevents enterohepatic circulation by exchanging potassium ions for thallium ions, creating a concentration gradient that facilitates the movement of thallium into the gastrointestinal tract. Animal studies have shown that Prussian blue not only reduces the half-life of thallium and decreases its concentration in vital organs such as the brain and heart, but also improves survival rates. Typically, these studies demonstrate a reduction in half-life by approximately 50%. Although controlled trials in humans are lacking, case reports and series suggest that Prussian blue provides clinical benefits. However, interpreting these findings can be challenging because of the concurrent use of other therapies. Prussian blue is generally well tolerated, with constipation being the primary adverse effect. It is often administered dissolved in a 15% mannitol solution or alongside a high-fiber diet. The recommended dosage for adults and adolescents is 9 grams daily, divided into 3 doses of 3 grams each every 8 hours. In children, the advised dose is 3 grams per day, divided into doses of 1 gram every 8 hours. Some experts advocate for higher doses ranging from 150 to 250 milligrams per kilogram per day. Extracorporeal drug removal methods such as hemodialysis or a combination of hemodialysis and hemoperfusion may offer some additional benefit in treating thallium poisoning. These methods are particularly considered when treatment is initiated shortly after massive exposure or in patients with underlying chronic kidney disease or acute kidney injury caused by thallium. However, despite earlier beliefs that hemodialysis might be highly effective, the actual amount of thallium removed through this process tends to be modest. Research has not demonstrated that hemodialysis is superior to simply inducing forced diuresis, which is the increased production of urine. Forced diuresis is generally not recommended because there is a lack of convincing evidence supporting its use, and it may worsen neurological toxicity if combined with potassium. Potassium supplementation is contraindicated as it can negatively impact mental status, increase lethality, and promote the redistribution of thallium into the central nervous system. Although it can increase the elimination of thallium through urine, this benefit is limited. Dithazone and dithiocarbamate, also known as diethyldithiocarbamate, have been discontinued due to their side effects. Dithazone can cause diabetogenic effects, and dithiocarbamate can form a lipophilic complex that redistributes thallium into the central nervous system, potentially exacerbating neurotoxicity. Traditional chelating agents, such as ethylenediamine tetracic acid, diethylenetriamine pentacetic acid, dimercaprol, and dipenicillamine are generally ineffective in promoting the excretion of thallium. In some cases, they may even increase the concentration of thallium in the brain. Water-soluble analogs of dimercaprol, including dimercaptopropane sulfonic acid, have also failed to decrease tissue concentrations of thallium in animal models. Although Suxheimer showed improved survival over controls in one animal study, this benefit came at the cost of increased thallium concentrations in the brain. Iron chelators such as deferoxamine and defersyrox are still considered too preliminary in their research to be recommended for clinical use. In the field of toxicology, especially when addressing heavy metal poisoning, it is important to understand that elemental phosphorus, despite its high toxicity, is fundamentally a nonmetal rather than a heavy metal. Its toxicological profile and management strategies differ significantly from those of classic heavy metals such as lead, mercury, arsenic, and cadmium. For these metals, chelation therapy often serves as a primary treatment. Our discussion will primarily reference the content from Chapter 84 to PDF, which focuses on phosphorus, and will compare its properties and management approaches with the broader principles of heavy metal poisoning where relevant. Elemental phosphorus has a long and complex history as a toxic agent. Historically, it has been responsible for significant health issues, especially through exposures affecting the gastrointestinal system or the skin. One notable occupational disease associated with phosphorus exposure is known as phossy jaw or mandibular osteonecrosis. This condition was prevalent in the 19th century among workers involved in match manufacturing, where chronic exposure to phosphorus vapors often led to this serious health problem. Interestingly, this condition is now also observed in patients undergoing treatment with bisphosphonate medications. Today, exposure to elemental phosphorus is rare in developed countries. However, it remains a concern in developing nations. Such exposures are often due to ingestion of phosphorus-containing firecrackers or pesticides, or from civilian phosphorus burns. It is important to distinguish between different allotropes of phosphorus. White phosphorus, also known as yellow phosphorus because of its discoloration and impurities, is by far the most toxic form. In contrast, red phosphorus is a more stable and less toxic allotrope. White phosphorus was historically used in friction matches and is still present in fireworks and incendiary munitions. In some countries, it is also used as an insecticide or rodenticide, although its use as a pesticide has been banned in many areas due to its severe toxicity. The toxicokinetics of elemental phosphorus are not fully understood. White phosphorus is soluble in lipids and is well absorbed through most routes of exposure, including ingestion and contact with skin. However, quantitative data on absorption are limited. The presence of alcohol or lipids may enhance intestinal absorption. After absorption, phosphorus distributes widely throughout the body, initially concentrating in the liver and later accumulating in bone, kidneys, brain, and heart. Excretion of phosphorus occurs primarily through the kidneys, with a minor amount eliminated via feces. The amount of white phosphorus that is severely toxic when ingested orally is reported to be around 1 milligram per kilogram of body weight. Historical accounts have noted fatalities resulting from as little as 3 milligrams ingested by a child. The exact mechanisms behind systemic toxicity caused by elemental phosphorus are not entirely understood. It is commonly regarded as a general protoplasmic poison. Electron microscopy studies have revealed early morphological changes in the rough endoplasmic reticulum, which occur before any changes become apparent in the nucleus or mitochondria. Elemental phosphorus can interfere with ribosomal function and protein synthesis, and it can also lead to lipoperoxidation. Histological examinations show that it causes the accumulation of lipids inside cells in various organs, including the liver, heart, brain, and kidneys. Dermal exposure to white phosphorus results in both thermal and chemical burns. White phosphorus spontaneously oxidizes in the air to form phosphorus pentoxide, which subsequently hydrolyzes to produce phosphoric acid. Both of these chemical reactions are highly exothermic, generating heat that causes thermal burns. Additionally, white phosphorus particles can spontaneously ignite at temperatures above 30 degrees Celsius, and embedded particles may continue to oxidize, leading to ongoing tissue injury. Phosphorus pentoxide is also highly hygroscopic, meaning it readily absorbs moisture, which causes rapid dehydration of tissues. The combined effects of these processes result in severe burns that tend to heal more slowly than typical thermal burns. Inhalational exposure to phosphorus smoke or vapors, which include a mixture of phosphorus oxides and unburned particles, can cause irritation of the mucous membranes and the respiratory tract. This irritation may lead to symptoms such as cough, hoarseness, wheezing, as well as swelling or inflammation of the larynx. Historically, prolonged inhalation of these substances has resulted in a condition known as phossy jaw. Additionally, chronic exposure can lead to other health issues, including anemia, a reduction in white blood cells, and persistent cough. The classical clinical presentation of acute elemental phosphorus ingestion typically follows a 3-stage model. However, this pattern may be more the exception than the rule, as many patients do not exhibit clearly defined stages. During the first 24 hours, patients often experience gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and diarrhea. These symptoms result from direct corrosive injury to the gastrointestinal mucosa. Notably, both vomitus and stools may emit a luminescent glow or smoke, and a garlic odor might be detectable. In some cases, especially with larger ingestions, sudden cardiovascular collapse and death can occur during this initial stage. The passage discusses different stages of a medical condition. The first stage may be due to direct toxicity to the blood vessels. The second stage occurs between 1 and 4 days, potentially lasting up to 10 days, and is characterized by relatively quiet symptoms. The third stage involves severe multi-organ failure. This includes acute liver failure, which presents with symptoms such as high bilirubin levels, blood clotting problems, low blood sugar, and elevated liver enzymes. Additionally, there is acute kidney failure, evidenced by decreased urine output, blood in the urine, protein in the urine, pus in the urine, and damage to the kidney tubules. Encephalopathy, arrhythmias, and cardiogenic shock are also common. Liver injury during this stage is usually located around the portal areas, with fatty infiltration and extensive tissue death. Other significant effects include neurological, cardiovascular, and hematologic manifestations. Neurologically, altered mental status, coma, seizures, and involuntary muscle twitching have been reported, sometimes occurring without initial gastrointestinal symptoms. These neurological abnormalities are associated with a worse prognosis. Cardiovascular effects beyond early collapse include changes in heart electrical activity, such as inversion of the T wave on electrocardiograms, prolonged QT interval, slow heart rate, and abnormalities in the ST segment. Hematologic effects observed include variations in white blood cell counts, such as leukopenia, decreased white blood cells, and leukocytosis, increased white blood cells, as well as suppression of bone marrow activity, leading to decreased granulocyte counts. Prognosis generally correlates with the dose ingested, with larger ingestions leading to worse outcomes. Survival for 3 days is a good prognostic sign, though late deaths from cardiac, hepatic, or renal failure can still occur. Dermal exposures can also lead to significant mortality. There are no specific laboratory tests available to establish a diagnosis of phosphorus poisoning. Serum elemental phosphorus levels are not available in clinical settings, and serum phosphate concentrations do not correlate with free phosphorus levels in the body. Therefore, diagnosis primarily depends on a detailed history of exposure to a product containing phosphorus. It is also supported by characteristic signs such as gastrointestinal outputs that smoke, luminesce, or emit a garlic odor. Additionally, phosphorus burns may be indicative of exposure in a military context involving munitions. Crucially, there is no specific antidote for phosphorus poisoning. Treatment focuses on decontamination and aggressive supportive care. For ingestion, gastric lavage may be considered shortly after a large ingestion. Cold tap water should be used to act as a heat sink due to the exothermic oxidation of phosphorus. It is important to minimize air introduction during lavage given phosphorus's reactivity with air. Activated charcoal is unlikely to be beneficial. For dermal burns, immediate and thorough irrigation with cold water is essential to clean the wound and remove phosphoric acids. Large particles should be removed with forceps and placed in water. The use of copper sulfate for wound irrigation is explicitly outdated and harmful, as it can cause severe systemic toxicity, massive hemolysis, and death due to copper ion absorption. Similarly, potassium permanganate solutions are not recommended. While dilute silver nitrate theoretically aids visualization of particles, minimal human data support this practice, and copious water rinsing remains paramount. Ultraviolet light, Wood's lamp, can help visualize phosphorus particles in wounds. Rigorous monitoring of vital signs, electrolytes, potassium, calcium, phosphate, and renal and hepatic function is essential for supportive care. Complications such as encephalopathy, hypoglycemia, and coagulopathy related to hepatotoxicity should be managed conventionally. Renal failure may necessitate renal replacement therapy. Corticosteroids have not shown benefit, and acetylcysteine, while postulated to limit oxidant injury, has not demonstrated a survival benefit in small case series. Healthcare worker safety is paramount due to the potential harm from liquid or solid phosphorus, which can be found in vomitus, diarrhea, and contaminated clothing. Proper personal protective equipment is necessary to protect against fumes and direct skin contact with phosphorus. Children, especially in developing countries, are particularly vulnerable to phosphorus poisoning due to exposure to firecrackers and rodenticides. The progression of the illness and its treatment in pediatric patients are similar to those in adults. Elemental phosphorus is known to cross the placenta and has been anecdotally used as an abortifacient in pregnant patients. However, there have been no reported cases of toxicity to the fetus or birth defects. Therefore, the management of pregnant patients should be the same as for other patients. Elemental phosphorus in the context of heavy metal poisoning presents a unique challenge. Unlike many other heavy metals such as lead, mercury, arsenic, cadmium, thallium, or cesium, there is no specific chelating agent or antidote that effectively removes elemental phosphorus from the body to reverse its toxic effects. For comparison, lead poisoning can be treated with agents like calcium sodium edetate, dimercaprol, or Suxymer. Mercury poisoning is often treated with agents such as dimercaprol, dimercaptosuccinic acid, or dimercaptopropane sulfonic acid. Arsenic poisoning can be addressed with dimercaprol, dimercaptosuccinic acid, or dimercaptopropane sulfonic acid as well. Cadmium poisoning is treated with dimercaptosuccinic acid, dimercaptopropane sulfonic acid, or diethylenetrylamine pentacetic acid, but not with dimercaprol or penicillamine. Thallium or cesium poisoning is typically treated with Prussian blue. Although some chelators such as N-acetylcysteine have been theoretically explored for their antioxidant properties, they have not demonstrated a significant survival benefit in cases of elemental phosphorus poisoning. The fundamental difference lies in the nature of phosphorus as a nonmetal, which influences its primary mechanisms of toxicity. Phosphorus causes direct cellular damage through protoplasmic effects, interferes with protein synthesis, and induces oxidative stress. Unlike many heavy metals, it does not simply bind to enzymes or displace essential metals. Consequently, the treatment of elemental phosphorus poisoning focuses on vigorous decontamination and meticulous supportive care to manage the multi-organ dysfunction it causes. This approach contrasts with the use of specific chelating agents typically employed for heavy metal detoxification. This distinction highlights the diverse toxicological mechanisms involved and underscores the need for tailored treatment strategies for different elements, even within the broader category of elemental poisoning. Zinc is an essential nutrient that plays a crucial role in supporting over 200 metalloenzymes and various physiological functions within the body. However, despite its importance, zinc can become a significant toxin when exposure exceeds the body's physiological limits, particularly in cases of heavy metal poisoning. Historically, zinc has been used by human civilizations for thousands of years. The Babylonians, over 5,000 years ago, employed zinc alloys, while ancient Egyptians used zinc oxide for treating topical lesions. In the late 1800s, occupational exposure to zinc in workers involved in the production of brass was identified as a health concern, leading to the recognition of a condition known as zinc fever. Today, this condition is understood as a form of metal fume fever caused by inhalation of zinc fumes. Industrial activities such as mining have also contributed to environmental contamination with zinc. This contamination has led to increased zinc levels in the tissues of affected populations, resulting in adverse clinical effects. Overall, while zinc is vital for health, excessive exposure can pose serious health risks, underscoring the importance of managing and regulating its use and environmental presence. Zinc is an element that exists primarily in two common oxidation states, as elemental zinc and as zinc ions. It forms numerous compounds, including zinc chloride and zinc oxide. Metallic zinc tends to form a protective coating of zinc oxide or zinc carbonate when exposed to moisture. Similar to other transition metals such as iron and copper, zinc ions can participate in reactions that generate reactive oxygen species. These reactive species can cause tissue damage, affecting both local areas and the entire system. Zinc is an essential nutrient, and its average daily intake in the United States typically ranges from 5.2 to 16.2 milligrams. The recommended daily allowances are 11 milligrams for men and 8 milligrams for women, increasing to 12 milligrams for pregnant and nursing women. This mineral is found in a variety of foods, including leafy vegetables, meats, fish, and poultry. Zinc tends to accumulate significantly in red blood cells, reaching concentrations 6 to 7 times higher than in serum. Physiologically, zinc plays a crucial role in more than 200 metalloenzymes, such as acid and alkaline phosphatases, alcohol dehydrogenase, carbonic anhydrase, superoxide dismutase, and DNA and RNA polymerases. It is also vital for gene expression, where it forms structural motifs known as zinc fingers that bind to specific regions of DNA. Additionally, zinc contributes to membrane stabilization and vitamin A metabolism. The mineral is essential for the development and maintenance of the nervous system. It supports fetal growth, and some studies have indicated that zinc supplementation during pregnancy can lead to higher infant birth weights and larger head circumferences, especially in women at risk. Zinc also influences olfactory and gustatory functions. Lower zinc levels have been associated with impairments in the senses of smell and taste, possibly due to abnormalities in enzymes such as gustin and carbonic anhydrase, which depend on zinc. Furthermore, zinc is involved in immune function, although its complete role remains not fully understood. Zinc therapy has shown mixed results in treating general infectious diarrhea, but appears to be beneficial in cases involving Shigella species, where it helps improve antibody responses and increases levels of B lymphocytes and plasma cells. Finally, zinc supplementation has been shown to reduce the duration and severity of the common cold when administered within 24 hours of symptom onset. It can also decrease the incidence of colds and reduce school absenteeism in children when taken over prolonged periods. Zinc deficiency, also known as hypozinsemia, is a condition characterized by a distinctive combination of symptoms. It typically presents with dermatitis, especially around the extremities and mouth area. Patients may also experience diarrhea and hair loss, known medically as alopecia. The condition can be effectively treated with the administration of oral zinc salts, which help restore zinc levels in the body. Zinc has a complex relationship with other metals, particularly copper, which plays an important role in toxicology. One notable aspect of this interaction is its therapeutic use in treating Wilson disease, a condition characterized by excessive copper accumulation in the body. In such cases, administering zinc stimulates the production of metallothionein, a protein that binds metals and helps eliminate copper from the blood and tissues. However, this mechanism can also lead to toxic effects if zinc is taken in excess, resulting in zinc overdose and associated toxicity. Metallothioneins, low molecular weight proteins rich in thiol ligands, bind to various metals including zinc, copper, cadmium, mercury, and silver, and are essential for metal homeostasis. While metallothioneins regulate the peripheral utilization of zinc and copper, excess zinc absorption leads to upregulation of metallothioneins, which unfortunately have a higher affinity for copper, resulting in excessive copper elimination and decreased copper absorption. This copper deficiency, induced by chronic zinc exposure, is the primary driver of its chronic toxicity. Zinc salts are also used to enhance the solubility of pharmaceuticals like insulin. Conversely, oral zinc salts can decrease the absorption of certain orally administered beta-lactam antibiotics, such as cephalexin, by inhibiting intestinal transport peptides. The toxicity of zinc is highly dependent on the route of exposure, with salt forms generally being the primary concern rather than metallic zinc. Defining acute and chronic toxic doses is challenging due to a lack of human studies. Acute toxicity due to oral exposure to zinc salts primarily manifests as gastrointestinal distress. This includes symptoms such as nausea, vomiting, abdominal pain, and gastrointestinal hemorrhage. Solutions of zinc chloride, especially those with concentrations exceeding 20%, are highly corrosive. They can cause partial and full-thickness burns to the oral mucosa, pharynx, esophagus, stomach, and laryngeal and tracheal structures, even from small unintentional ingestions. Severe cases can occur, such as when a neonate receives a highly concentrated zinc solution through total parenteral nutrition, which can lead to hypotension, respiratory failure, and even death. Inhalational toxicity varies depending on the water solubility of the zinc salt involved. When zinc chloride, which is highly water-soluble, is inhaled acutely from sources such as smoke bombs, it can lead to symptoms including tearing, nasal inflammation, difficulty breathing, noisy breathing, chest pain behind the sternum, inflammation of the upper respiratory tract, and acute respiratory distress syndrome. These effects typically occur without systemic involvement of the kidneys or liver. Exposure in enclosed spaces worsens the outcomes, increasing the risk of severe health consequences. In contrast, inhalation of zinc oxide, which is much less water-soluble, is associated with a condition known as metal fume fever. This condition presents with symptoms such as fever, chills, cough, muscle pains, muscle cramping, chest discomfort, difficulty breathing, dry throat, and a metallic taste in the mouth. Usually, this syndrome is benign and individuals can develop tolerance over time, reducing the severity of symptoms upon subsequent exposures. Dermal exposure to zinc oxide, such as in products like baby powder, is generally non-irritating to intact skin. However, there have been rare reports of pruritic, pustular rashes in workers exposed to zinc oxide. In addition, isolated cases of urticaria and angioedema have been observed following exposure to zinc oxide fumes. Regarding other acute effects, ingested zinc-containing objects like pennies, which are composed of approximately 97.5% zinc, can become lodged in the esophagus. When these coins come into contact with gastric acid, they can release zinc ions that may damage the local esophageal tissue. Rare instances of kidney complications have also been reported. These include hematuria, which is blood in the urine, following ingestion of liquid zinc chloride, and acute tubular necrosis associated with intravenous zinc sulfate administration. Chronic exposure to zinc primarily manifests as a deficiency of copper, which can lead to various systemic effects. One significant impact is on the hematologic system. This condition often results in a reversible form of sideroblastic anemia, characterized by anemia and granulocytopenia. Additionally, there are abnormalities observed in the bone marrow, including vacuolated myeloid and erythroid precursors and the presence of ringed sideroblasts. These hematological changes are attributed to the deficiency of copper induced by excessive zinc intake. Neurologic impairment is a syndrome sometimes referred to as zinc swayback. It encompasses symptoms such as sensory ataxia and progressive myelopathy, which are often associated with elevated zinc levels and low copper concentrations in the body. A common source of unintentional zinc exposure has been found in zinc denture creams, which can contain significant amounts of zinc. This excess zinc can lead to a condition known as myeloneuropathy. Neuroimaging studies in affected individuals frequently reveal increased T2 signal intensity in the dorsal columns of the cervical spinal cord, a finding similar to what is observed in vitamin B12 deficiency. This pattern suggests Wallerian degeneration and demyelination of nerve fibers. Additionally, magnetic resonance imaging scans of the brain may show bilateral subcortical hyperintense abnormalities on T2-weighted images. These brain findings are also believed to be secondary to copper deficiency. There is a potential link between zinc exposure and demyelinating diseases, such as multiple sclerosis. Certain clusters of these cases have been reported in areas with high occupational zinc exposure or environmental metal contamination. However, a definitive connection has not yet been established. Research into zinc's role in the development of prostate cancer indicates that men who take zinc supplements at doses greater than 100 milligrams per day or for longer than 10 years may have an increased relative risk of developing advanced prostate cancer. Despite these findings, zinc is not currently classified as a carcinogen by the International Agency for Research on Cancer or the Environmental Protection Agency. Chronic inhalation of zinc oxide can cause a reduction in blood copper and serum calcium levels. Nevertheless, there are no reported long-term effects on respiratory function or chest imaging related to this inhalation. Due to zinc's ubiquity, sample contamination is a concern. In suspected zinc poisoning, measuring serum copper and ceruloplasmin concentrations is essential, given the strong inverse relationship between zinc and copper levels. Urine zinc concentrations are not well defined, but normal levels are generally considered less than 500 micrograms per day. Neuroimaging, particularly MRI, can reveal characteristic findings of copper deficiency myelopathy in chronic zinc exposure. The management of zinc salt toxicity varies depending on the route and severity of exposure. For instances of acute oral zinc salt poisoning, treatment is primarily supportive. This includes ensuring adequate hydration and administering antiemetic medications to control nausea and vomiting. To address abdominal discomfort, healthcare providers may recommend the use of medications such as histamine type 2 receptor antagonists or proton pump inhibitors. In cases where gastrointestinal decontamination is necessary Whole bowel irrigation is advised, particularly when zinc-containing objects like pennies have been ingested. Chelation therapy for zinc toxicity has limited evidence of effectiveness in humans. One agent, calcium disodium edetate, has been used successfully in some cases. However, this compound can deplete essential metals such as zinc, iron, manganese, copper, and mercury. Among these, the depletion of zinc is usually the most clinically significant. Sometimes, therapy combines calcium disodium edetate with dimercaprol, also known as British antilewisite, to treat zinc poisoning. Nevertheless, the use of dimercaprol is limited because it can increase the elimination of copper, which may not be desirable. Other chelators, such as diethylenetriamine pentacetic acid, 2,3-dimercap-topropane, 1-sulfonate, and related compounds, have demonstrated potential in animal studies and laboratory settings to promote zinc excretion. However, further research involving living organisms is necessary before these substances can be recommended for clinical use. Additionally, an iron chelating agent called deferiprone has been observed to incidentally reduce serum zinc concentrations. Overall, chelation therapy is regarded as a reasonable approach for cases of severe zinc toxicity. Copper supplementation can be an effective treatment for patients experiencing copper deficiency related to zinc overload. When administered orally, copper often successfully corrects hematopoietic effects and can prevent further neurological deterioration, sometimes even without the need for chelation therapy. The initial recommended doses are 2 milligrams of copper given intravenously or 6 milligrams taken orally each day, with a gradual reduction over time. For patients with neurological effects and mild hematopoietic symptoms, copper sulfate alone may be sufficient. However, for those with hemodynamic instability or other severe systemic symptoms, chelation therapy is necessary to manage their condition. Inhalational toxicity occurs when individuals are exposed to harmful substances through inhalation. It has been reported that intravenous administration of N-acetylcysteine, a medication used to treat certain toxicities, can increase urinary zinc excretion in patients who inhale zinc chloride fumes. To prevent such exposures in occupational settings, it is essential to use appropriate respiratory protective equipment, such as filter particulate respirators. Ensuring proper respiratory protection measures can significantly reduce the risk associated with inhaling toxic fumes. Dermal decontamination is crucial when dealing with zinc salts, and it should be performed using water and soap. However, if there is exposure to metallic zinc, water should not be used as zinc metal can ignite when it comes into contact with moisture. The appropriate treatment in such cases involves mechanically removing any metallic particles. Additionally, applying mineral oil can help protect the metal from moisture and prevent further ignition. In the broader context of heavy metal poisoning, zinc's unique interaction with copper highlights the complex interdependencies of essential metals in the body. While chelation therapy exists for various heavy metals such as lead, mercury, arsenic, cadmium, and cobalt, the primary treatment for chronic zinc toxicity involves addressing the resulting copper deficiency. This is often achieved through direct copper supplementation rather than relying solely on zinc-specific chelators. This situation underscores the importance of a comprehensive understanding of trace metal metabolism when managing cases of metal intoxication. For healthcare professionals managing exposures to diverse elements and heavy metals, a concise understanding of their unique toxicological profiles is paramount. This content provides a targeted overview of 6 critical substances: antimony, arsenic, cobalt, mercury, thallium, and elemental phosphorus. Antimony, with the chemical symbol Sb, has a toxicological profile that closely resembles that of arsenic because of their chemical similarities. It exists in various oxidation states, primarily in the trivalent and pentavalent forms, which are most commonly encountered. Antimony is used in medicine for treating leishmaniasis, especially in the form of sodium stibogluconate, and industrially in the manufacturing of alloys, semiconductors, fire retardants, and batteries. In terms of toxicokinetics, antimony is poorly absorbed when ingested orally, but the extent of absorption depends significantly on the chemical form and the size of particles inhaled. The trivalent forms tend to accumulate in the liver and thyroid gland, whereas the pentavalent forms accumulate in the liver, spleen, and bones. Excretion of pentavalent antimony predominantly occurs through the kidneys, while trivalent forms are primarily eliminated via fecal routes. The pathophysiology of antimony poisoning involves interference with the sulfhydryl groups of enzymes, which inhibits cellular respiration. The trivalent forms are generally more toxic because they have a higher affinity for erythrocytes and sulfhydryl groups, contributing to their increased toxicity. Clinically, antimony poisoning can affect multiple organ systems. Patients may present with gastrointestinal symptoms such as nausea, vomiting, diarrhea, and abdominal pain. Cardiovascular effects include cardiotoxicity, prolongation of the QT interval, ventricular arrhythmias, and sudden cardiac death. Pulmonary symptoms can include irritation and pneumoconiosis, while hematologic manifestations may encompass leukopenia and hemolysis, particularly with exposure to stibine. Other affected systems may include the renal and hepatic systems, skin, and musculoskeletal system. Diagnosis is typically suspected in patients presenting with gastrointestinal or pulmonary symptoms or ECG changes, especially if there is a history of exposure. Confirmation involves measuring antimony concentrations in blood or urine, as serum levels are not timely indicators. Treatment focuses mainly on supportive care, including fluid resuscitation, cardiac monitoring, and antiemetics. Gastrointestinal decontamination with activated charcoal or whole bowel irrigation may be considered in certain cases. Chelation therapy is primarily indicated for poisoning with trivalent antimony. The preferred agent is dimercaptosuccinic acid, also known as Succimer. If oral administration of Succimer is not feasible, dimercaprol or British anti-Lewisite may be used. However, chelation therapy is not supported for toxicity caused by pentavalent antimony. Arsenic, represented by the chemical symbol as, exists in various forms with differing toxicological effects. Predominantly, inorganic arsenic salts such as trivalent arsenite and pentavalent arsenate are of concern due to their toxicity. The trivalent forms generally exhibit greater acute toxicity compared to the pentavalent forms. Organic arsenic compounds found in seafood, like arsenobutane, are considered to have low toxicity. However, some compounds like melarsoprol are highly toxic. Additionally, arsine gas, which is a distinct gaseous form of arsenic, is known for causing intravascular hemolysis. In terms of pathophysiology, trivalent arsenic inhibits the pyruvate dehydrogenase complex and enzymes essential for protecting cells against oxidative stress. In contrast, pentavalent arsenic disrupts energy production by substituting for phosphate in biochemical processes. The liver biomethylates arsenic into less toxic forms, although this process can also produce more acutely toxic trivalent methylated species. Clinically, acute arsenic poisoning presents with an abrupt onset of symptoms including nausea, vomiting, watery diarrhea, and abdominal pain. These symptoms can progress to shock, arrhythmias, and metabolic acidosis. Patients may subsequently experience neurological decline, pancytopenia, and cardiovascular effects. Chronic exposure usually manifests as widespread hyperpigmentation and palmar-plantar hyperkeratosis. Patients may also develop sensory peripheral neuropathy, anemia, leukopenia, and an increased risk of cardiovascular disease. Diagnosis primarily relies on clinical presentation and exposure history, complemented by laboratory tests such as urine arsenic concentration, which measures total and speciated forms of arsenic. Blood, hair, and nail analyses can also be utilized, but should be interpreted with caution. Treatment involves supportive care, including rehydration, vasopressors, and sodium bicarbonate to manage metabolic disturbances. Gastrointestinal decontamination can be achieved with activated charcoal or whole bowel irrigation. Chelation therapy is the mainstay of treatment and should be initiated promptly. The key chelators include dimercaprol, dimercaptosuccinic acid, also known as Succimer, and dimercaptopropane 1-sulfonate. Among these, dimercaptosuccinic acid and oral dimercaptopropane 1-sulfonate are often preferred over dimercaprol due to their better safety profiles and convenience. However, in cases of acute arsine poisoning, dimercaptosuccinic acid or dimercaptopropane, 1-sulfonate, may be considered as alternatives. Cobalt, with the chemical symbol Co, has a history of use in the treatment of anemia and as an additive in beer. These uses historically led to conditions such as beer drinker's cardiomyopathy and goiter. In contemporary times, exposure to cobalt is primarily occupational, often associated with cemented tungsten carbide, known as hard metal, and from orthopedic implants, which can result in a condition called arthroprosthetic cobaltism. Regarding its toxicokinetics, cobalt is absorbed variably through the gastrointestinal tract, with absorption rates influenced by the presence of iron deficiency or overload. Once absorbed, it is mainly eliminated through the kidneys. Cobalt acts as a multi-organ toxin by inhibiting enzymes and interfering with metal cations like magnesium, manganese, zinc, and calcium. It induces oxidative stress and disrupts iron binding, leading to various biological disturbances. Clinically, cobalt toxicity can manifest as cardiomyopathy, thyroid hyperplasia, and goiter, along with increased red blood cell production, gastrointestinal distress, neurological deficits such as seizures, retinopathy, hearing loss, and neuropathy. Chronic inhalation of cobalt particles can cause a condition known as hard metal disease, characterized by interstitial lung disease. There's also a concern regarding cobalt's potential to cause cancer. Diagnosis of cobalt poisoning involves measuring cobalt concentrations in body fluids, although such assessments are not typically available rapidly in emergency situations. Urinary cobalt levels are useful for evaluating elimination, while whole blood cobalt measurement better reflects the total body burden of the metal. Treatment strategies include aggressive supportive care with whole bowel irrigation recommended for removing solid forms of cobalt. Chelation therapy can be considered for cases with manifestations of toxicity affecting organs. Several chelating agents, such as calcium disodium, ethylenediamine tetracic acid, and N-acetylcysteine, have been used based on case reports and animal studies. In cases of cobalt toxicity related to prosthetic implants, removing or revising the prosthetic device is crucial, although chelation may have limited effectiveness due to the large reservoir of cobalt in such devices. Mercury, also known as mercury with the chemical symbol Hg, exists in several forms, each with distinct toxicokinetic properties. Elemental mercury, which appears as vapor, is highly lipid-soluble and can cross the blood-brain barrier rapidly. When inhaled, it is primarily absorbed through the lungs and can oxidize into inorganic forms within the body. Inorganic salts of mercury, such as mercuric salts, are mainly absorbed through oral ingestion. These forms can cause corrosive damage to tissues and tend to concentrate in the kidneys, affecting renal function. Organic mercury compounds, such as methylmercury, are highly absorbed when ingested and tend to accumulate in red blood cells. They can readily cross both the blood-brain barrier and the placental barrier, posing risks to the nervous system and developing fetuses. The elimination of organic mercury from the body predominantly occurs through fecal excretion. Pathophysiology. All forms of mercury avidly bind to sulfhydryl groups on enzymes and proteins, which causes widespread dysfunction. Elemental mercury vapor directly damages the airways. Inorganic mercury can cause renal tubular necrosis and oxidative stress. Methylmercury leads to severe damage to the cerebral and cerebellar cortex. In terms of clinical presentation, elemental mercury exposure through inhalation typically causes mercury fume fever, whereas chronic exposure can result in tremors, erythism, and inflammation of the gums and mouth. Inorganic mercury exposure, often through ingestion, causes immediate caustic effects on the gastrointestinal tract, such as ulceration and hemorrhage, along with acute kidney injury due to renal tubular necrosis. Chronic exposure to inorganic mercury can lead to symptoms affecting the kidneys, gastrointestinal system, and nervous system. Organic mercury exposure produces profound neurological effects, including abnormal sensations, impaired coordination, visual field constriction, and cognitive deficits, often after a latent period. Prenatal exposure to organic mercury can cause severe developmental delays in the fetus. The diagnosis of mercury poisoning is confirmed through the measurement of mercury levels in blood, urine, or tissues using collection materials that are free of mercury to prevent contamination. Urine mercury levels are considered most reliable for assessing exposure to elemental or inorganic mercury, as well as for monitoring chelation therapy. In contrast, measuring mercury in whole blood provides a more accurate assessment of acute organic mercury burden. Treatment involves immediate termination of exposure, decontamination, and supportive care. Chelation therapy is indicated for patients displaying symptoms. For elemental and inorganic mercury poisoning, the preferred chelating agents are dimercaprol and dimercaprol disulfide compounds, such as dimercaptosuccinic acid. Dimercaprol is generally reserved for severe inorganic mercury ingestions, but should be avoided in cases of mercury vapor exposure, as it may increase brain redistribution of the toxin. Regarding organic mercury poisoning, the most appropriate treatment is considered to be dimercaptosuccinic acid. Dimercaprol is not recommended in these cases, as it can facilitate the transport of mercury into the brain, worsening the condition. Elemental phosphorus, also known as phosphorus in its pure form, is a nonmetal and not classified as a heavy metal. Therefore, its management differs significantly from that of heavy metals, as chelation therapy is not effective for treating phosphorus toxicity. White phosphorus, which is also called yellow phosphorus, is the most toxic form of this element. Historically, it caused a condition known as phossy jaw among match workers. Today, white phosphorus can still be found in fireworks, incendiary munitions, and some pesticides used in developing countries. In terms of toxicokinetics, elemental phosphorus is lipid-soluble and is well absorbed through ingestion and skin contact. Once absorbed, it distributes widely throughout the body, including the liver, bones, kidneys, brain, and heart. The pathophysiology of phosphorus poisoning describes it as a general protoplasmic poison. It disrupts the function of ribosomes, impairing protein synthesis, and leads to lipoperoxidation. This causes intracellular lipid accumulation. Exposure through the skin can result in burns caused by a combination of thermal heat and chemical reaction due to spontaneous oxidation and exothermic reactions. Inhalation of phosphorus vapors can lead to respiratory tract damage. The clinical presentation of acute ingestion often follows a three-stage model. The first stage occurs within the first 24 hours and is characterized by gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and diarrhea. Vomitus during this stage may luminesce or produce smoke and typically has a garlic odor. Sudden cardiovascular collapse can also happen at this stage. The second stage is a period of quiescence where symptoms may temporarily subside. The third stage involves multi-organ failure, which can include acute liver failure, acute renal failure, encephalopathy, and irregular heart rhythms. In addition to these stages, there are other effects to consider. Neurological symptoms, such as altered mental status and seizures, can occur. Cardiovascular abnormalities and hematologic effects may also be present. Diagnosing this condition can be challenging because there are no specific laboratory tests or serum levels that are reliably available. Instead, diagnosis relies heavily on a patient's history of exposure and characteristic signs, including luminescent vomitus and the garlic odor. Treatments for poisoning with substances like copper sulfate and potassium permanganate involve no specific antidote or chelating agent. Management primarily focuses on decontamination and providing aggressive supportive care. If ingestion occurs, gastric lavage with cold water might be considered because the cold water helps absorb heat, although activated charcoal is generally unlikely to be beneficial. For skin burns, immediate and thorough rinsing with cold water is essential, along with the mechanical removal of particles. It is important to note that copper sulfate and potassium permanganate are now considered outdated and potentially harmful methods. Supportive care includes rigorous monitoring of vital signs, electrolyte levels, and the functions of the kidneys and liver. Management of organ failure is conducted as necessary, following standard medical practices. Thallium is a highly toxic heavy metal that exists in two common forms: the univalent form, which carries a single positive charge, and the trivalent form, which has 3 positive charges. Historically, thallium was used in medicine to treat conditions such as syphilis and ringworm, and it was also employed as a rodenticide. However, current exposures to thallium are rare and typically occur only through malicious poisoning or contamination of illicit drugs and herbal products. Thallium is rapidly absorbed into the body through all routes of exposure, including inhalation, ingestion, and contact with intact skin. Once absorbed, thallium quickly redistributes within cells and tends to concentrate in highly perfused tissues such as the kidneys, liver, and brain. It undergoes significant enterohepatic recirculation, which prolongs its half-life in the body and increases the potential for toxicity. The pathophysiology of the condition primarily involves mimicking potassium ions due to their similar ionic radii, which interferes with processes dependent on potassium, such as the sodium-potassium ADPase pump. Additionally, it inhibits enzymes containing sulfhydryl groups and disrupts mitochondrial energy production. Clinically, the presentation is characterized by a classic triad that includes acute gastroenteritis, polyneuropathy, and hair loss. In the early stages, patients often experience gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and diarrhea or constipation. These may be accompanied by stomatitis and a bluish discoloration of the gums. As the condition progresses to the intermediate stage, cardiovascular symptoms become apparent, including a rapid heart rate and high blood pressure. Neurologically, patients may exhibit painful tingling sensations or numbness, muscle weakness, cranial nerve palsies, coordination difficulties, tremors, and signs of brain dysfunction. In the late stages, hair loss usually occurs 2 to 4 weeks after exposure, and characteristic white lines on the nails, known as Mees lines, become visible. Renal effects tend to be milder compared to the other symptoms. The diagnosis of thallium poisoning is confirmed by elevated thallium concentrations in bodily fluids, especially in a 24-hour urine collection. Treatment focuses on enhancing the elimination of the toxin from the body. Decontamination should be performed with orogastric lavage within 1 to 2 hours of ingestion. Activated charcoal is highly effective due to its ability to bind thallium in the gastrointestinal tract and its enterohepatic recirculation, making it suitable for both acute ingestion and enhanced elimination. For larger ingestions, whole bowel irrigation is recommended. Enhanced elimination of thallium can be achieved using specific agents such as ferric cyanophorate or Prussian blue. These agents act as ion exchangers within the gastrointestinal lumen, preventing further enterohepatic recirculation and increasing fecal excretion of thallium. They are generally well tolerated, with constipation being the main side effect. Certain therapies are discouraged or considered ineffective. Potassium supplementation is contraindicated as it can worsen neurotoxicity. Traditional chelating agents, including ethylenediamine tetrachic acid, British anti-leucite, dimercaprol, 2,3-dimercapto, 1-propanolsulfonic acid, and Saximer, are generally ineffective against thallium poisoning. In some cases, these agents may even increase thallium concentrations in the brain. Zinc is an essential nutrient that plays a vital role in human health. It is involved in the functioning of over 200 metalloenzymes, which are enzymes that require metal ions to work properly. Zinc also contributes to gene expression, helps stabilize cell membranes, supports nervous system development, boosts immune function, and enhances the senses of taste and smell. However, despite its importance, zinc can become toxic if consumed in excessive amounts. When zinc levels are too high, the body responds by producing metallothionein, a protein that binds metals. Metallothionein has a higher affinity for copper than zinc, which can lead to a deficiency of copper. This deficiency is significant because it can cause various chronic toxic effects and health problems. Therefore, maintaining a proper balance of zinc is crucial for optimal health, as both deficiency and excess can lead to serious consequences. The clinical manifestations of zinc chloride poisoning can be categorized into acute and chronic effects. Acute exposure primarily causes gastrointestinal distress, including nausea, vomiting, abdominal pain, and hemorrhage. Zinc chloride solutions are highly corrosive, which can exacerbate these symptoms if ingested. Inhalation of zinc oxide vapors may lead to a condition known as metal fume fever, characterized by flu-like symptoms. Chronic exposure to zinc compounds can result in copper deficiency, which manifests as sideroblastic anemia, a disorder where the bone marrow produces ringed sideroblasts rather than healthy red blood cells, and neurological impairments. These neurological issues include sensory ataxia, progressive myelopathy, and a condition often referred to as zinc swayback. Magnetic resonance imaging of the spinal cord in affected individuals often reveals characteristic findings associated with these neurological impairments. Diagnosis of copper deficiency involves measuring serum copper and ceruloplasmin concentrations, which are essential indicators. Neuroimaging, particularly magnetic resonance imaging, can reveal signs of myelopathy caused by copper deficiency. Treatment strategies depend on whether the toxicity is acute or chronic. For acute cases, supportive care such as hydration, antiemetics, and proton pump inhibitors is primarily recommended. Whole bowel irrigation is also suggested for gastrointestinal decontamination. In cases of chronic toxicity or deficiency, oral copper supplementation is often effective in correcting hematopoietic issues and preventing neurological deterioration. Sometimes this approach can be successful without the need for chelation therapy. In more severe cases, chelation therapy with edetate calcium disodium has been used successfully, although its effectiveness specifically for zinc toxicity is limited. Other chelating agents are currently under investigation.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.